Those who have been attending the Lambeth Together Public Forum for some time will know the format, but I'm just going to explain so everybody's absolutely clear, and also just underscore one or two tweaks we're making to the way in which things work going forward. So it's an informal meeting for people who come off their own bat or are representing organisations or have particular issues that they're concerned about and are interested in health and care, to meet local decision makers, to have a chance to ask questions, to share with us what matters to you and your community in relation to health and social care, and to influence plans for health and social care in Lambeth. And indeed now, under the new structures, we're working in the plans for health and care across South East London. I do want to be very clear that this session is one where the floor is very much yours if you're someone who's come to ask a question or join in the discussion. We have a number of colleague board members here who are responsible to different areas of our work and are here to support us and help us in this session and in the board meeting. We are, as I speak, adding a link to the chat for our board members, so you can see who they are. There's a board gallery which tells you a bit about what everybody does and what they're bringing to the board. So take a look at that if you want to see how the board is comprised and who the people who sit around the table are. So it really is all about questions. I do need to underscore that we may not necessarily have an answer to your question straight away, but we always do, and I hope those who have been attending for some time will vouch for this. We do follow up with fuller responses if we can't give you a clear and direct answer in the session itself. We publish all the responses on the Lambeth Together website, so you can subsequently, having asked your question and been promised additional material, and indeed been promised a sort of script of what was said, you can find that on the Lambeth Together website. We don't have time generally to have in-depth conversations about individual cases, and I know that there often are individual cases people would like to discuss, but we do make time and provide opportunities to have those conversations offline. So not lots of conversation about individual cases, but we do our best to support people who do want to raise those sorts of issues to understand how we can help going forward. As chair, I think it's really important to hear from a really wide range of people, and I'm keen to make sure that anyone who's come along with a question or something to say has a chance to speak up to 2 o'clock when the main board starts. And I'll be trying to fit as many people in as possible within the hour that we do have. To help with this, if you've got a lot of questions, and some people often have a series of things they'd like to ask, I'd ask you to sort of get the most important one in first, and then if we have time we can come back to the others, and I'll be asking colleagues, so I would never pretend to have even a fraction of the answers to the questions that are asked, but we have a really expert, very well briefed and very experienced team around the table, the virtual table, and I will often be turning to colleagues to answer the questions, and they're going to do that sort of briefly and succinctly. We know there has been at least one question via email, certainly one that I've seen. Forgive me if there are others, but I think there's only one, and we'll ensure we come to that. So there's a good balance between the sort of questions notified to us in advance and ones that are from the floor where people haven't notified in advance, but they just want to ask the question because it's important. As I said before, anything we don't get time to cover, we make sure that we follow up either over email or by a separate conversation. We are committed, and we always try to do this, we're committed to using very straightforward language, but if we do slip into jargon or use language that's not clear, do feel free to stick your hand up and ask us you know, what an ICS is, or why we're talking about the ICB, or whatever other latest piece of the NHS and care architecture that we've now created, do ask us questions about any of that, because it does change all the time. I would say to everyone, if you could, when you're not speaking, please mute yourself, because that does help to screen out any background noise, which can be off-putting. And great if you want to have your camera on for this, particularly for this session where we want to see people who have come to participate in the public forum. You know, do feel free to keep it on. We're always delighted to be able to see who's in the virtual room. To ask a question, if you raise your hand in the chat, I hope people are familiar with that process by now. If you're not, and if I'm not seeing you, feel free to sort of wave a bit, and I'm sure I will have my attention attracted and bring you in. It would be great if, when people ask questions, you could say your name, and if you are speaking as a representative of an organisation or any other body, perhaps you'd let us know about that too, because that helps us understand the background. You're also very welcome, if you prefer not to speak, and it's not everyone's idea of a great time, to turn on your camera and mic and ask us directly. You're more than welcome to post a question in the chat, include your name, and again we'll try and come to that before the end of the meeting. The only other tweak that it's worth bringing to your attention around how this meeting's working and we think will work going forward is that, unlike previous public forums, we're not going to have a presentation about an important health topic at the top of the meeting. We've been obviously doing that for the last 18 months, 2 years on COVID. We have covered other topics as well. We're not doing that so that we've got plenty of time for questions, because really that's the point of the public forum, for people to be able to engage in a dialogue with everyone who's in the room. So let's get started. Especially want to welcome anyone who has not been here before and would like to ask a question, but I'm very much in the hands of the meeting as to who'd like to ask the first question or raise the first issue. And I can see Gay Lee with her hand up. So Gay, over to you.
Thank you very much. And I hope, can you hear me all right?
We can, Gay, yes.
Oh, good, fine. Well, first of all, I wanted to say a thank you, Jim, to you. I should say my name's Gay Lee, and I'm from Lambeth Keepar NHS Public. And a couple of weeks ago, we had a national day of action about the health service and our concerns about it, particularly to do with the lack of funding, the lack of pay for staff and the staffing problems that are ensuing, and also the amount of privatisation that's going on. And I wanted to say thank you to Jim, because he came to address a meeting we had in Windrush Square and to support us in this way. And it was really appreciated. It got into the South London press, small, beautiful article and photograph. And I also particularly wanted to say thank you for being open about the fact that this the new structures, the integrated care system, which is being implemented at the moment for the NHS, your honest answer that it actually isn't going to solve any of the major problems of the NHS, one or two of which I've just outlined. So I did want to express our appreciation to you for doing that. But my question was actually, and I'll try and be as brief as possible, about the closure of Minikid House, the NHS nursing home that was in Hazelbourne Grove until well over a year ago now, when it was closed. And I know this has been brought up almost every Matters Together meeting, and I'm sorry to bring it up again, but there are 2 points I'd like to make. One is, we were promised that there will be some kind of public forum to discuss the options for the use of Minikid House in the future, and our hopes were that even if it couldn't be kept open as a or reopened as a nursing home, that it could be used for some health service facility. And so I wanted to know when, if anybody had any views when that might be. But in that context, I happened to notice, and this is pure coincidence, a GSTT, a Guy St Thomas's board meeting, the minutes of a meeting that were held in November, which seemed to suggest, a subcommittee meeting that was held in November, that seemed to suggest the decision had already been made to use to close the site down, completely to sell it off unless King's College Hospital had some use for it. And we've had various meetings with people since that date, I think it's the 23rd of November, this Strategy and Performance Subcommittee. And nobody has mentioned the fact that this decision has been taken. So is this why we haven't had a date yet for a public discussion about the possibilities? And, you know, has this decision been made?
Okay,
and Marianne, the Lambeth councillors, was involved in the decision making about this.
Okay, thanks, Kate. Kate, there's a lot in that, but the sort of the two, yeah. Thanks, Kate. I'm going to ask Jane Bowie to come back. Jane, if you could deal with the 2 points. One is that public forum meeting that I know Guy's and St Thomas's are committed to having. Is that imminent? And secondly, has a decision already been made? I'm pretty certain I know the answer to the second one, which is it hasn't, and there are still lots of options in play. But Jane, do you want to just quickly update us? And the one thing I'd say before I bring Jane is that Sarah Austin from Guy's and St Thomas's, who people know is usually an assiduous attender of this board, she can't be with us today. I think she sent her apologies. So if there's anything that Jane isn't able to share, I'm sure Sarah would do that. Sarah, who's been very responsive on this issue to anyone who's asked questions, I'm sure she'd be happy to do that. So Jane.
Thank you, Jim, and thank you for your question, Gay. And in the first instance, absolutely, Sarah and myself have been working closely. So if there's anything additional that I need to get confirmation from Sarah about, I certainly will. In brief, Gay, no, there hasn't been a decision made by GSTT of the use of the Mini Kid House building. And then secondly, you're absolutely right, there was a commitment made about having a public forum, which, as Jim said, I know GSTT, with me in support, are very committed to carrying out. The reason we haven't quite got a date for that yet is because GSTT is exactly looking to actively explore what options could be used for that building and for that site. I think they're wanting to absolutely see if there's anything that can be done, and when they've got some scoped or potential uses which can be articulated, then we will be looking to arrange a public forum.
Thank you very much, Jane. Hope that answers the question, Gay. I'm going to move on because there's other questions that are already being tabled in the chat, I'm very pleased to say. Odeon Cousin, who has been a recent attender, and very pleased to see you back, and thank you very much for the questions you've placed in the chat. Would you prefer I read them out, or would you like to ask them yourself? Save me the trouble. Okay, if you want to quickly ask them, and others while you're asking them, you can see them written in the chat at the moment. So over to you.
Well, hopefully quick.
And we'll take them one at a time. Yeah.
There's 2 questions about the current COVID vaccination. I know it's always COVID all the time. I recently asked at the vaccine bus, the health and well-being bus, which is traveling around the borough, whether people without NHS numbers or people with unclear immigration status who were unwilling to produce ID could be vaccinated, and the staff at the bus seemed a bit unclear and unsure, and the answer was maybe. I think the answer was no, but we'll look into it. I think this is just important because I think it's the policy that people can, and I know there are quite a few people who are hesitant because they don't want contact with the system. They don't want their names on any records because they're scared of the Home Office, to be frank. And I wonder if that could be clarified with the staff of all the walk-in centres.
Thank you for that question. Very important question. I'm going to ask Andrew Ayres to answer that. Andrew, do you want to introduce yourself and respond to Odeon's question?
Thank you, Jim. So I think the answer to the question is yes. You don't need all your details and so on to be able to get a vaccination, but perhaps more importantly, as you point out, is do all the people in the sites that we are offering vaccination kind of understand that. So it's helpful to have that kind of feedback. We thought we had been very clear with all our sites around the kind of minimum requirements and so on and so forth. But what we will do is we'll go back out and remind people that remains the case. Certainly when the kind of first rollout of the vaccinations came through, this was a significant issue. I think we thought we got the messages clearly out there, but clearly that's not the case in 100% of cases. So we will go out and remind people. I hope that's helpful.
That is helpful. One thing that they did say was they need to have a way to register it, and they weren't sure how they note down this was given to this person if they don't know who this person is. So I'm sure there's a box they can tick, but they just didn't know what it was.
Yeah, we'll go back and remind them. Obviously, in terms of recording people's vaccinations, that's a bit more difficult. If they're not registered with the practice or the NHS and so on, but people can access the vaccination in the first instance. I don't know, Gary, whether there's any more you wanted to add to that answer. Gary is leading on primary care and many aspects of the vaccine programme.
Yeah, hi. Yes, I'm Director of Primary Care and Transformation in Lambeth for CCG. So just to say, and I think Catherine has just posted it in the chat, you absolutely don't need to be registered with a GP, to have an NHS number, or to provide any immigration status. Some of our sites like Montgomery Hall have had a consistent footfall every day for more than a year of people who are all of those things. But as you've clearly identified, perhaps not every single member of staff on every single access point is aware, so we will go back round that loop again. Sometimes that's because staff change, and you do also have volunteers who are obviously local people themselves, so absolutely well made point, and we will go back round that loop. But yes, the details in the chat also post you to where we've officially also said this to the public as well.
Thank you, Andrew and Gary, and I think the point you're making there, Gary, is a good one. And I think, you can never say enough times how the system is supposed to work in order to remind people whose days aren't filled with understanding how they can ensure they get vaccinated and find the right locations and ensure that they're doing it at the right time. People need reminding on those issues because people have busy and stressful lives and are thinking about other things. So the messaging has to be good, and I believe in Lambeth it really has been. Odeon, you've got a second question there, so I'm in the absence of others with their hands up, I'm going to ask you to ask that very related question.
And this is actually why I got on the talk today, because this happened yesterday, and I said, yeah, I should ask them about this. Yesterday I was in a local pharmacy, I won't name it, and picking something up, and an older woman was asking, can I get the COVID vaccine here? And the pharmacist said, no, we don't do that. So how can I get it? They said, oh, just get online and check. And I understand it's not their job, they don't offer it, but given the importance of pharmacies, and they're being promoted as important portals for people to access care, would it be possible? I then got on my phone and helped her find the nearest walk-in centers and when the bus is going to be in the neighborhood, etc. But is there any way to disseminate that information via pharmacies? Because obviously people do go into pharmacies and ask, and it appears that the pharmacies which are not acting as walk-in vaccination sites are not equipped, or they're not interested. So I wonder if that could be a constructive suggestion for how to expand access.
Thank you very much. I'll perhaps ask Andrew to come in on that one as well.
And again, I'll perhaps turn to the colleagues as well. But just to say again, thank you very much. As Jim said, greatest laid plans, don't always reflected 24/7 with every single member of staff across the health and care system. But actually, pharmacies played a fantastic role in vaccination in Lambeth. We've had more pharmacies offering vaccinations than any other borough in South East London, and I think in London as a whole. But so they played a really big role. But as you say, not every pharmacy is offering vaccination. In a sense, their answer is a right one, because all of the information on all the sites is online, and as you found, easily accessible to yourself. But obviously, not everybody is as comfortable about going online. But part of the problem is keeping up to date. So our access points change a fair bit, and they are different for different cohorts of individuals, so different for children compared to adults and so on. But we do our best to make sure that everyone in the system knows how to get the most up-to-date information about what's open when and for who. So we do share that. And again, I think your example is a good one, though. We will go back around the system and remind people how they can better signpost people to how they find that information, and perhaps help them themselves in the same way that you did, because that's the kind thing to do, really, isn't it? So
It's
thank
what we
you
hope
for that.
everyone would do, but it often
Exactly.
doesn't happen, and it's precisely
Exactly.
the people who don't have that access that end up
Exactly.
slipping through the cracks. So a sheet sent around to every pharmacy, for example, that said, we don't have the vaccine, but here are the 2-3 pharmacies nearest us with that do, would probably solve a lot of the problem.
It might do, but that changes quite a bit on occasion. So that some of that it's quite a changeable picture. So how we would keep that up to date would be our challenge, but which is why we use the kind of websites. But I think, you know, that's not beyond the wit of us to work with our pharmacies to help them communicate better. I think the second thing, though, is that particularly for the older cohorts, it's not always about them finding out where the vaccines are available. Our vaccine centres should be and are contacting them. So as new kind of boosted kind of cohorts open up, or so on and so forth, we do invite people in directly in to book into our services and so on. And we're just about this week to start the new booster campaign for over 75. So from your description, this person might have fitted into that, and it might be possible that that's what she was looking for. And it should be that they will get an invitation, direct invitation into services as well. So there's a kind of double-edged thing. There's a thing about making easily accessible for people looking for it, but also directly inviting people in to services. And I wonder, Gary, again, whether you'd be able to just say a bit more about how particularly older people might be being invited in for the next phase.
Yeah, thanks, Andrew. And again, it is a good point. So we have more than 60 pharmacies, community pharmacies in Lambeth. 13 of them are actually, as you say, active vaccination sites. We probably have spent most of our time talking to those 13 and perhaps not necessarily keeping the rest of them up to date, apart from more general communications across the whole borough. So I think it's a good point made. Yes, I mean, so we've got 13 community pharmacies that are live at the moment. We still have 4 general practice groupings, but they're mainly working from 2 sites, just to emphasise how it does change. And not all of those sites are vaccinating 5 to 11-year-olds. Not all of them will be vaccinating in quite the same way at over 75. So it is kind of, and they don't all offer walk-ins. So it really is quite a nuanced message. You know, there are 3 types of vaccine. There are 4 different doses. There are, 15 separate sites. It's a recipe for having a leaflet which is actually more harm than good by the time it's sent out. So we have had examples in the beginning of the pandemic where unfortunately somebody might go somewhere at a certain time and find that there wasn't actually an opening. Which I'm sure was also damaging to them in terms of them going back. So what I would say for now is, yes, Spring Booster campaign has officially begun. For the over 75 group, they should now be being called in by their GP practice if they're registered in particular for their what would be their 4th dose, so their 2nd booster, if that makes sense. And it needs to be at least 6 months after their 3rd dose. So again, there's a sequencing thing here. So not everybody is eligible as of today, but they will be over the next couple of weeks. There is also another group of patients. So anyone who's over the age of 12 who's on immunosuppressive treatment is also now due their next dose, which for them would be their 5th dose. So it's all rather confusing. And again, a lot of those will be under the care of the hospital. So they may well, for a much smaller group of older people, they'll be contacted probably by their hospital as well. So 2 offers. We have also been updating as Andrew said, the online presence. So the main NHS landing page, as well as our local pages, do have the very latest map of where you can go, because we still also have walk-ins available for older people as well. That's assuming the older person was registered in Lambeth, of course. We may well have found that they're from Southwark and they may just be in a Lambeth pharmacy, just to add a bit more confusion.
Anyway, hope that helps. And quite a changeable picture, but absolutely what we're really keen to do is to make sure it's as easy as possible to people to find where they can get their vaccination as early as they can once they become eligible for it. And of course, for most people now eligible for some vaccine or another at this point. So.
Thank you very much for those answers. And just looking in the chat, we've got a sort of suggestion from Annie Marr saying, is it possible to put a flow chart up in pharmacies that they can be directed to? Then with the correct numbers, they should call to book. So I think that's really just about more public information on display in pharmacies so that people feel they can get that information in the way they want it, and as well as obviously asking questions. So is that something we could think about?
We could definitely think about that. Because of the changing nature, it's sometimes easier to direct people to a single place where we can easily track the changes. That's the only thing I would add, because these posters often go out of date. So just having if you like, a signpost to where they can find the information is sometimes a bit better and helps to keep it up to date.
Okay, thank you, Andrew, and thanks for that additional suggestion, Annie. I'm now going to come to the email question we had provided to us in advance. I don't know if it's available to put up on the screen. It is indeed. So in the absence of Jan, who I don't think is with us, I'm just going to quickly read it out and then we'll get an answer. So Jan O'Malley has asked, the Minister for Health, Edward Arger, announced on the 17th of March that the charging regulations will be amended to allow Ukrainian refugees full and free access to the NHS for 3 years. This shows how fast the government can change policy for a particular group of migrants while leaving it in place for those with darker skins and from other parts of the world. Will Lambeth Together seize this opportunity to call on the government to abolish all NHS charges? So let me perhaps just start on this as chair, but also as a political representative for our borough, particularly speaking on health and social care issues. And I suppose what I would say to Jan is that I think I am, and my colleagues in Lambeth on the council are on record many times making our view known that charging prohibits people using care and that it's therefore wrong. And we've communicated that view to ministers. We're in agreement with the Patients Not Passports campaign, and the point of that campaign is to get rid of these sorts of charges. To state the obvious, it's not in our gift to make that change, but I, as a political representative, I'm very happy to continue to make that view known and to work with others who also agree with that agenda. I don't think it's for Lambeth Together as a delivery body, making health policy and delivering the best possible health and care services we can locally to be part of that campaign, but the political representatives certainly are. What Lambeth Together can do and is doing is to work with partners like Guy's and St Thomas's in order to uncover the facts as to how that charging works, what its possible perverse incentives and outcomes might be, and to give us a better understanding of the framework in which we're working so that we can locally, if possible, have the discretion to make changes, notwithstanding, as everybody will realise, we work within a national framework which we aren't able to countermand. I wonder if Andrew is able to update us on some of the work that's going on to start to understand the effects of charging and how we, with Guy's and St Thomas's, are taking that forward.
Yeah, thank you, Jim. And just before I do that, I think there's a couple of factual points probably to note. And the first is that across the whole of the UK, refugees and asylum seekers, even if they've only got an active application or appealing, remain fully entitled to free NHS care. So whether you're a refugee from Ukraine or anywhere else, you still have that entitlement. It only becomes an issue for those people who become refused asylum seekers and have less recourse to, or no recourse to public funds and public services. So for the vast majority of refugees, whether they come from Afghanistan or Syria or from the Ukraine, their refugee status gives them access to UK healthcare, which is obviously very important. The rules that follow on from that, though, for those in a refused position are really quite complex. But even for those, any kind of urgent care, whether it's in primary care or A&E or so on and so forth, is available to anyone presenting in UK facilities. So that's really important. statement to make, I think. I think the second bit is around the work we're doing with initiated by guys at St Thomas's and underway. We met with them at our Lambeth Together executive group yesterday. That work remains underway in GSTT, and we have an invitation to join with them to consider how they take that forward and assess the kind of impact that they are experiencing across their own services. So work underway, and we will be responding separately to Jan on the earlier questions that she prompted to us, which we've given a partial answer to date, but we'll obviously be able to give a fuller one once that work's been completed by the Trust. I hope that's okay, Jim.
Thank you very much, Andrew. Useful update, and I'm sure Jan will be eager to see the response to her latest email, which, as you say, we're preparing. Just want to.
I think Adrian might wanted to add something as well. I thought I'd sort of.
Yep, very good idea. Adrian, did you want to jump in on this issue and how you're seeing it? Yep.
Thank you, certainly, and obviously supportive of what has been said already. I think a couple of other things to mention. I think there are recognisably numbers of people who do not understand that they are in fact eligible, and so I think there's a task to make very clear the eligibility for all those who are eligible, as Andrew had described. And I think the other thing is one of the sort of active attempts to be more open and welcoming, which I think in general practice we have the safe surgeries approach. So a number of Lambeth practices, a significant number of Lambeth practices are signed up and accredited as safe surgeries, which involves training at the practice, but also making the surgery welcome to all.
Thank you, Adrian. I think those are really good points. I think it's not well understood, the charging system. I do think there's a real opportunity for us to fill the vacuum a bit and make sure that those who are eligible for care, free care, absolutely get what they're entitled to. So really good extra point. I'm just looking around to see if there are any other questions people would particularly like to ask. If there are, do stick your hand up. Given that the subject of sort of Ukrainian refugees fleeing an appalling conflict zone, and some at least wishing to come to this country and being able to do so once they've penetrated the huge thicket of bureaucracy that seems to have been thrown in their way. But assuming they do get here, there clearly are local arrangements being put in place to ensure that they get the support that they need, and the situation in terms of the framework for that is evolving all the time. But I thought it might be useful because Andrew Ayres has been briefed very recently, in fact today, on what arrangements are in place. I wonder if, Andrew, you could just quickly set out the current position, because I think that's useful for people on this call and in this meeting to know about, so they can communicate to others how the system's going to work as we understand it at the moment. Yeah,
so obviously much of the policy is still being developed on a national level, and as that policy is developed and we receive information locally in our boroughs and through the NHS, we're putting in place the preparations we need to do to safely receive people and to support those who are sponsoring them in the UK. So there are essentially two schemes at the moment that are either already starting to operate or will operate for Ukraine nationals who wanting to come to the UK. One is around those people who have family here already, and that scheme is already up and running, and people are being granted visas on the back of that, and beginning to come to the UK. But I think more substantial will be the Homes for Ukraine scheme, where in a number of phases. The first phase will be where people can put themselves forward as sponsors who can then be matched to Ukrainian individuals and families, and then there's a kind of visa process by which they will be supported to come to the UK. We don't know what the numbers will be yet on that, but we do know that for those people who are successfully matched and pass the initial checks and then arrive in the UK, there will be a need to wrap around support for them, and that will be support for both the sponsor, the people who are opening their homes to Ukrainian refugees, but also to the refugees arriving themselves, and that kind of support will be obviously both in education for children. It'll be around obviously housing through supporting the sponsors. It'll be around wider health and care, and opportunities into employment and other things. So quite a lot of things that we'd need to work on. We're doing what you'd expect of us in terms of the right checks. So we'll be doing the right checks on things like housing and safeguarding, and obviously putting people in touch with wider support networks which will support their stay in the UK. Individuals will be allowed to stay for up to 3 years once they've been given granted a visa application, and people sponsoring will receive £350 a month in support for the first year. As a minimum, though, they have to offer that accommodation for the next 6 months. So they're the kind of basic rules for this. And obviously, as we learn more and as we start to find out about what the likely numbers will be, we can start to frame the scale of our response within individual boroughs based on the kind of location of where the sponsor homes will be. The next phase might involve community organisations and a kind of wider groups. We're not quite sure when that next phase might start, but it's likely at that point there might be larger numbers involved, although quite a lot of uncertainty as to how many people might wish to be coming to the UK at this point. Perhaps I'll stop there, Jim. There's still a lot to learn in terms of how this will be taken forward.
Thank you, Andrew. And I think one of the key points is that public authorities, so the council and the NHS, primary care, there's a role for us to sort of reach out to both the families arriving, but also the sponsors, and make sure they have all the information they need about how the family they receive can be supported, and indeed they as sponsors can be supported to ensure that that opportunity and that new home and the arrangements go well. And certainly we are thinking about that very carefully in the council at the moment, what sort of information people might need and how we can make sure we get that to them. I do see in the chat a question, and it's an interesting question. I'm not sure we're necessarily going to have a full answer to it, but Annie is asking, it would be good to make clear what medical info will be shared, or whether there is a firewall between NHS and the Home Office to people seeking care. And this is a slightly vexed issue generally. And as I say, we don't know in full what the arrangements will be with regard to Ukrainians coming to the UK for safety and support. Adrian, you have some experience of this, I think, with your work, particularly with migrant and refugee communities. Do you have any thoughts on what might be the case?
I can try and say something, and the first thing I would say is, from a general practice perspective, as general practitioners, we are the data controller for the information that we hold about our patients, and therefore have a duty to keep that data safe and only share it appropriately with the appropriate levels of consent. So I think that's one part of an answer, probably not a complete answer. And I think the other couple of observations. One is that the work in supporting accommodation for refugees and asylum seekers, the Home Office clearly plays a role in that, but I don't think that role should give the right to access medical data, in my view. But I think there has also been, some painful historical sharing of data that has felt inappropriate. I'm aware of some past history with people receiving, homeless people receiving services where information has been shared inappropriately, not through general practice, I would add. But so I think it is a good point, and happy to try and seek further assurances from the Home Office on what they would do. But I think to give at least some assurance of what the general practice part of the world does, and I assume that other colleagues providing health and care, would have similar responsibilities as data controllers.
Thank you very much, Adrian. And it's clearly an evolving picture. We can only go on what the practices have been hitherto. We're very committed to sort of confidentiality, as you've said, Adrian, making sure that people receive the best care they can and aren't in any way inhibited from seeking care. And that's often the issue about data sharing, isn't it? So really good to know. Clearly, the picture is that we as a council and the NHS are doing our best to understand the framework. We'll be reaching out to support both families and those receiving people who need support, and we will keep you posted on how the framework that that gets evolved by government and that we work within is moving forward. If there aren't any other questions on that, I was just going to very quickly ask the Director of Public Health and others on the board just to quickly update us on the position with regard to COVID. People will, if they've been observant and if the courier service that I think the council is using has been efficient, they should be starting to receive a letter talking about living with COVID-19, how to keep yourself and your community safe. It obviously talks a little bit about the very changed guidance with regard to COVID, the fact that legal requirements to self-isolate have gone, and students and pupils no longer have to take 2 tests a week, and the fact that free testing is going, much to the regret of some of us. So a very changed landscape. But I wonder within that whether Ruth Hutt is able to just update us on what the position is with regard to COVID, numbers of cases, and how that might be affecting both individuals and sort of public services in the borough at the moment. And then we can obviously happy to have any questions about how we all keep ourselves safe going forward. So Ruth.
Thanks, Jim. So I'm Ruth Hutt, Director of Public Health. There is a substantive item on the main agenda in relation to this as well, living with COVID. So for those of you staying for the meeting, then there'll be a bit more information on how we are moving forward with this. But the reality at the moment is that the case rates that are being reported are going up. They've gone up probably about 50% in the last couple of weeks. But because lots of people aren't reporting their test results, or a lot of people probably won't even get a confirmatory PCR test now, it's quite difficult to work out what the actual numbers are. In terms of the impact on the health system, that's where people are being tested still. So if you go into hospital, you'll still get tested. So we can get a sort of sense of what's going on. And although the numbers of people with COVID within the acute settings is creeping up a bit, it's certainly not rising as quickly as it's like to be in the community. And it tends to be incidental. We're picking up those infections because people are admitted for other things. Having said that, what we are starting to see is some pressure on our staffing and within our groups of staff that are still being required to test. So social care, NHS staff are still required to test. So we are still picking up those infections, and that creates some challenges for us from a workforce perspective. But although there's no longer a legal requirement to self-isolate, the recommendation is still that people should self-isolate. And our recommendation is still that if you're in busy places, you should consider to wear face coverings, those sorts of things to keep yourself safe as well. And obviously the messaging around vaccination remains there, and that offer will continue way beyond the scaling down of testing. So the official end dates for testing will be next week, apart from a very small group of people that will continue to be able to access testing because they work in health or social care or in particular vulnerable settings. There's not a lot else probably to say at the moment. As far as I'm aware, there have been no further variants or anything else that have been picked up. So whilst we're seeing an increase in cases at the moment, well, some of that probably is being driven by a subvariant of Omicron. A lot of it will be driven by the fact all the other non-pharmaceutical interventions have been removed. So the social distancing, mask wearing, people just being out and about more, all of that will also be adding to that increase in case rates. The challenge for us going ahead will be that it will be quite difficult to detect some of these changes in the community because the data that we get on testing won't be as comprehensive as it's been up to this point in time. So
thank you very much, Ruth. Really,
sorry, I was just going to add.
Sorry,
I can see the questions coming into the chat.
I was going to make sure. Yeah, do you want to cover those? That'd be great.
I'm happy to cover them. And I think just without sort of rehearsing the item that's later in the agenda, because there is some detail in there about what some of those plans are, and just to say that there are bits we just don't know yet. So there's a question, I think, about does the DPH have the authority to actually require things like masks? The short answer is no, and it's a real challenge, I think, the messaging, because what we found, even when there was still a sort of mandate to wear masks on public transport, people weren't doing it. We got to a point where people just weren't doing it. So there's something about, you know, picking the point at which you would start to then re-implement those sorts of measures in a way that you get compliance back, rather than sort of half in, half out situation we found ourselves in. And what some people are choosing to do is using a sort of higher spec mask, really, that probably gives them a bit more protection to them individually, as opposed to when everybody is wearing masks which actually mutually protect people. The one thing I do have a little bit of control over is where we've got outbreaks in certain situations, then we could put in additional control measures. So if we have significant outbreaks, particularly in the more vulnerable settings like care homes, then at that point we might take additional measures. In terms of the arrangements for buying tests, we do know that there are a lot of pharmacies, Boots, for example, are making those tests available to buy. So that will be widely rolled out, I'm guessing. Some people have probably got a stockpile of LFDs. They saw that sort was coming and they've got their own little stockpile to work through at home. I'm sure a number of people on this call may well be in that group. But the reality is that going forward, people will need to buy LFDs, apart from if you're still required to test as part of your job. And that in those scenarios, then LFDs will be provided. And the question from Sue about the care home visiting, there was refreshed guidance that came out yesterday for care home. You do still need a test at the moment. What I'm not quite clear about is whether from next week, when testing is no longer widely available, whether that changes, but care homes will retain a supply of tests, so testing can still be available sort of at the point of entry. But generally, I know what's happening is most people are testing prior to going into a care home, particularly when they are the main carer. But it does create some real challenges, because it's, you know, another financial pressure for people, and they're not cheap, to be honest. The sort of price that they're coming out at the moment, they're okay for a one-off, but if you're visiting somebody every single day, then that's quite a different situation. So we will have to look at that once the final guidance comes out about whether there's something more we need to do to support that, if the guidance continues to be that people should be still testing.
Thank you very much, Ruth. There are some other questions coming up, some of which are specifically to you, but other of which are more general. So Annie is saying, will there be any financial support for low-income people, those on universal credit, to get LFTs, to get the tests? I don't think there is anything specific, but before Ruth comes in on that, I just would wish to give a big plug, as it were, to the Lambeth Household Support Scheme, which is very much available for people struggling to pay bills or afford food, particularly if they've been impacted in any way by COVID-19, including loss of work or change in economic situation. It's also available to people who need support, for instance, to prevent them having to enter institutional or residential care, or if there's a family or individual under exceptional pressure. So please do encourage people to apply to that scheme, which can make a very significant difference. That's only in place until the end of this month, although I think we will still be running some grants after the 31st of March. So I think that's, whilst that's not specifically about LFTs, it is very much funding that's available to support people who are in a difficult situation, either as a result of COVID or other circumstances. There's a question too from Odilon saying you can actually buy them for £1 each. Perhaps we can bulk purchase them to support people who are unable to buy their own. Ruth, did you want to have a quick comment on that? Is that something we could take away and think about?
So I think it's really about thinking about where in this new context we're moving into, when is it appropriate to use testing? There are some groups of people that will potentially want to test to protect those people they're caring for or going to see. There's another group of people where testing will be quite important because they can access treatment and it will enable them to get access to treatment early. So the sort of strategy around testing needs to link to those two things. I think the days of us all doing a test before we go out and widespread testing are probably numbered now. It may well be that if the situation changes, that might change and government policy might change and testing might become available again. But at this point in time, that does not look like the way we would go. So rather than people, I think we'd need to create some guidance around that for people about what the situations are, whether it would be a good thing to do to spend your money on testing, or even for us to support that. So that's really part of the work we need to do once we understand what the further guidance is that will come out in the next week or so. Tom had his hand up, so I don't know if he wants to add anything to this. I think
there's some hot news from Westminster that Tom's sharing with us.
That's right. I mean, I've just mentioned in the chat, it was really following up on what you were saying, Jim, about the household support scheme. So the Chancellor announced just earlier on that they were doubling the household support scheme. It's not clear yet what the timeline is for that, but certainly I think our expectation is that that there'll be continuing access to kind of that additional funding through the current measures, and we'll have to see what the timeline is to determine whether there'll be enough to do any additional work in that, but that'll be a work in progress over the next period.
Thank you, Tom. Very useful to have people who have got their eyes on other screens, so they can bring us latest developments from outside Lambeth as we go forward. So that's really helpful. And I noticed there's some information now in the chat about where you can get cheap lateral flow tests. And we're being assured that the person placing it has no connection to the company. That's a sort of declaration of interest we like. Do we have any other questions on this issue, on COVID, on arrangements to refugees, on anything else that we've covered in the last hour or so? Catherine, did you want to say something about how we make our public forums as accessible and as helpful to people as possible, and therefore use feedback from those who attend on how we can improve things? Did you want to? You've put that in the chat, but any thoughts about how we get people's views on that?
Hello there. Yeah, I'm very happy to say a few words, but I did take the opportunity to put a link to a very simple form in the chat. We're just trying to ensure that each time the public forum is held, that we reach out to community groups, organisations, networks across Lambeth, just to share the fact that this is a space, it's an opportunity for anyone who has an interest really in health and care in Lambeth to come along, start a conversation, ask a question. And so as part of that, it would be good to understand the experience of those who are here, on how it could be better for those of you who are here today. If you could fill that in, members of the public or people from groups, not the professionals, and then we can use that to understand who currently is coming. It's an anonymous survey, and your ideas also on who we might be able to reach. Please also feel free, if you had other ideas on how to expand the reach of the forum, to email in hello@lambethtogether.net. But the form is, we hope, fairly easy to complete. You just need to click on the link that's there. It's also posted on the Lambeth Together website on the board page. I'll put a link into the chat there as well. But it's just help us to create this opportunity together and reach out to more people, so that the board gets to hear more from more and very different people as well about what's important. That's all really.
Thank you very much. That's very much a process of us learning how to do things better, how to reach out better, and how to listen better. So yeah, do help us with that, please. Any other questions or comments or topics people wanted to raise before we close this part of the meeting and move on to the next part of the meeting, which is the formal board. So I've got 2 hands up. So we're going to hear from Carol first of all, and then Sue has some thoughts as well. So Carol.
Question for Andrew. I'm Carol. I work for the NHS, and I would like to know, have you got any information in chemists, vaccine centers for people who speak second language, whose second language is English?
Okay.
Thank you, Andrew. Yes, please.
Yeah, I'm fairly certain that most of our information is translated not into every other language, but is often available in other languages. I don't think every single piece of the information is, but certainly the key facts that people would need is available. I'm just looking to Catherine to see if there's anything more I could say on that.
I think it would probably be too large a task to provide in every setting across the whole of Lambeth information in every language, but certainly we have information available online and can have it translated, and people can access it themselves from the NHS website. If you'd like to contact hello@lambethtogether.net or contact me, my email, if there are particular languages that you haven't been able to access, I'll be very happy to help you to get the information that you need in that or those languages. I'll just put my email address in the chat here.
Thank you, Catherine.
Thank you. And certainly I know our comms team in Lambeth at the height of COVID were translating essential material into, I think, 11 different languages. That's obviously 11 key ones for Lambeth, but there are many more that people speak and are their first languages. So we do need to be continually thinking about that. Is that okay, Carol?
Thank you. Thank you.
Thanks
Great.
for the question. Sue.
Thank you.
Thank you, Jim. My voice is not very good, so can you hear me?
Yes, we can hear you very well, Sue.
Okay, I'm losing my voice. Just a suggestion for the next public forum. I wondered whether or not it was possible to have a summary of how well we actually did in Lambeth in getting all our populations across the different ethnic minority groups vaccinated, and what the lessons were that we think we learnt about how to maybe do that better next time, or how to change the approach for next time to make it more successful from the beginning, and to make it into a sort of possibility for a comment and question or a discussion issue, and encourage some of our wider population to come to the public forum to perhaps offer views if we felt that might be helpful. But the main point is, I think it would be useful to have a summary of where we have reached, because there's quite a lot of media coverage at the moment criticising the NHS for not doing enough, and I know we tried exceptionally hard.
Thanks very much, Sue. Andrew, did you just want to comment on what the right forum for that would be, or whether here is a good place to be landing that information?
So certainly, I think we should probably bring a report to the board itself, and then because I don't think it's for us to say to the public what they should be talking about in the forum, but absolutely we could bring some information, which then if members of the public want to have a debate here in this forum, then we can do that. If not, we can share that information through the board and have the conversation in the board meeting itself. So I think a good suggestion, not necessarily because vaccination is the only thing we do, obviously, but it has so many pointers and kind of issues that have been raised through the vaccination program about how we work with our different communities to encourage them to engage with the full range of health services on offer, including vaccination.
Thank you very much. Good. Well, look, that's taken us a tad over 1 hour. Thank you very much for all those who have asked questions and participated. We're sort of very keen to, as Andrew said, develop the forum so that it's the best possible place to have conversations about crucial health issues and care issues in the borough. So we look forward to seeing you at, I think, what will be our next public forum that I'm using my fingers to work out is probably May. So end of May, I would imagine. And in the meantime, please do follow up any of the issues that we've raised today and that you've very eloquently articulated in the form of questions to us. I'm now going to hand over to my co-chair, Dr. Di Aitken, who will be chairing the formal part of the board. So Di.
Thanks very much, Jim, and welcome colleagues, our board members, and welcome to the public. Before we start, I'm just going to remind everybody that this is a meeting in public rather than it being a public meeting. And so if most people could have their video off and on mute, unless you're speaking and contributing, the chat function is there and open and visible to everybody. I think all our presenters today are going to be using slides, but we'll be able to see them and all members will be visible during discussions. I don't think we have any new board members. I know, Gary, you're now a different type of board member. Before you were an assistant director in attendance and now you're a director as a member, so welcome. In terms of apologies, I think we've had 2 apologies from Sarah Austin from St Thomas's and Merlin Joseph, but we do have Karen here for Merlin. Is it Karen or Jeanette who's here for Merlin? And then we have one member who it's her last meeting. So Catherine Pearson, I think you're on the call, aren't you? Oh, lovely to see you. So Catherine has been our Healthwatch Lambeth Chief Exec since 2013, and you're leaving us, even though I know you're a long-time Lambeth resident and you know the borough inside out. And so you really have been a key member of our Lambeth Together partnership because of your knowledge and your perspective. And you've been making us keep focused on what really matters to local people. I would encourage everyone to have a fresh look at the Healthwatch Lambeth website, because you'll see that Catherine has supported service improvements in practices, in our hospital trusts, in community health settings and in social care, and highlighting the experience of patients and communities and producing really powerful reports, because they do these visits called enter and view visits. So I'd really encourage you to take a look at that. She's drawn our attention to issues of loneliness and social isolation, raised awareness of the needs of people with dementia, championed the rights of people with learning disabilities, and making sure that everyone has equally good health and care. Am I embarrassing you yet? In terms of working in partnership, she's overseen some incredibly important programmes that really have sought to tackle some of the deepest inequalities that are faced by Lambeth people. And I'm going to reference you hosting Black Thrive and also our Lambeth Learning Disability Assembly, and also the Advanced Care Planning Consortium. These were all hosted by Healthwatch and have made phenomenal changes in our system. As a board member, you've always brought invaluable insights and nothing but positive energy to our Lambeth Together strategic board. And I just going to say that I think you're a hard act to follow. And I would invite you just to say a couple of words, seeing as this is your last meeting. You're on mute still. We can't hear you.
I was saying, thank you very much, Di, and thank you for being so generous and giving me a quick opportunity to say this has been the best job in the world. And, the next chief exec will walk into a fantastic partnership with Lambeth Together, and we'll have every opportunity to sort of shine at what Healthwatch attempts to do. And that's all down to us and the way we manage things and our pledges. So I've loved working with you all. I am a Lambeth resident and I will continue to be involved, and I'm so proud to be living in a borough where the Alliance is going to be delivering so many interesting things, and I will continue to volunteer in the borough and be part of things. So thank you for everything, and well done us.
Oh, look, applause hands. Let me see if I can do that too. No. Okay, let's move on to our meeting. We've got quite a full agenda, and so I just wanted to ask all members, do they have any interest to declare on today's agenda? So I'm going to put my hand up straight away because I'm a GP and we have a primary care commissioning item.
The same for me.
And from myself.
Thank you. I can see Sadru's trying to unmute himself.
Yes,
and
me
Penelope's
too.
waving. Thank you. And,
same here for me.
Aha, great. So we've got everybody. And I think if Therese is on the call, she'll probably put her hand up too. She's our managing director of the Federation. So let's just note those declarations.
Thanks, Di. They're noted.
Thank you. Thank you. And then looking at our minutes from last time, does anyone have any comments, tweaks? Is everyone happy to approve them so that we can publish them online?
Happy to approve.
Thank you. Sue's got her hand up.
I just wondered, I did give my apologies, but they haven't been noted, and I wondered if they could be noted in the future.
Okay. Thank you. We'll just note that. I don't believe there's any matters arising, so we will move on to our first substantial agenda item, which is a discussion and presentation on Lambeth support for refugees and asylum seekers. And we have a full team here. So I'm going to hand over to my board colleague, Adrian McLaughlin, and then you can introduce the team.
Thank you very much, and thank you very much for the invitation for what I hope people will agree is an important conversation, and one that I think has always been important, but as we've spoken earlier, it has a particular topical added issue that I think is worthy of our attention. So the team, I think we're a small subset of the multiple folk who will be, giving services to refugees and asylum seekers in Lambeth, but introducing, or can introduce yourselves please, but Helena and Shazia, do you want to say hello? And I think you'll hear a little bit from all of us, and I'm sure there may be others who wish to join in as we go through. Helena and Shazia, do you want to say hello?
Hi there, it's Helena McGinty, Head of Asylum Support for Lambeth Council. Thanks, Adrian.
Yep.
And hi there, my name's Shazia Munir. I'm a GP and I'm the clinical lead on the health inclusion team at Guidance Trust.
Lovely, thank you. So I'm going to sort of set a bit of context. Apologies for the size of the slide pack, but I think much of this is more by way of reference and for sort of detailed consideration today. And I think the other general point to make is that I think given the nature of the conversations we're having, I think we will be trying the best we can not to mention specific venues or detailed numbers or things that could identify where people are receiving support for reasons I hope kind of make sense to people. So just noting that. And the last thing to say is, I guess, whilst we'll be talking through some of the things that I think are important, I'm pretty certain from myself that I cannot do justice both to the the level of need that I think you'll infer from what we're talking about, the trauma, the stories, and what has brought people to this country and to Lambeth. But I hope there's at least some sense of that. So given those kind of early caveats, let's kick off and read with a bit of introduction to the context, and then talking more about what is happening and then what might happen in future. So if we can go next slide, and we're going to be flying fairly fast through the first few here. And so, oh yes, it's slightly different. And actually the point's already been made, asylum seekers do not only arrive in this country by boat, they arrive by almost every route possible. But people are still arriving in this country by boat, mostly smaller ones than the ones that you'll see on the picture there. Next slide, please. And it's probably helpful just to give a brief introduction to some of the language we're using. There are recognised definitions for asylum seekers and for refugees. And I think also to make the point that this slide makes, and I think echoing what we spoke about earlier in the meeting, that all asylum seekers have the right to access services without charge in this country, and that the right to claim asylum is an international human right. And I think this is an important thing to recall. Next, please. This again, just really to give an indication of some of the process, not to dwell on this, but people can take these away and read the detail at their leisure. But to give a little history, next slide, please. This gives some links to some 400 years of refugee movement to the UK. So not a new thing. This is a long-standing response to a range of triggers that cause people to leave their homes and flee persecution, war, and a range of other things that drive people away. Next, please. So a few bits of numbers here, and noting that these numbers are in thousands. These are people, and you're looking at a graph of thousands of people, and giving some of the history of the comings and goings of people who seek here and what happens to them. Next, please. And again, sort of applications lodged, just looking at some of the numbers. Next, please. So a quick oversight of where people come from. So this is over 2019 to 2021, and you can see the countries that have where the most people have been fleeing from to come to this country. Next, please. And then you can also see that within the European Union, the countries that receive the biggest numbers of asylum applications. And so, listening to some people speaking, you might imagine that this country is one of the greatest recipients of people seeking asylum. Clearly, that is not the case looking at movement within Europe. And if we're looking more topically, then clearly many people are going to other countries, not just the European Union. Next slide, please. And one of the sad things to note is that a significant number of the people who do seek asylum actually end up in detention, and some of those are even in prison. I think again, just to look at the numbers and be aware of the experience that many people will be receiving. Next, please. And this looks at how many people leave the UK and what is the means of their leaving the UK, whether voluntary returns, enforced returns or port returns, of how people who've come to this country may leave this country rather than becoming settled in this country. Next slide, please. Talks a little about the decision making and the numbers that go into those who are settled in this country. And the next slide, I think, shows a graph about actually again looking at the process, and you can probably make out the numbers of those who are ultimately successful in settling in the UK. Next, please. And then this one just gives a hint of the time of that process, the number of people who are spending a vast amount of time in considerable uncertainty going through the asylum process before getting any sense of security and being settled, and that is a devastating time and far, far too long. And then I think the last one in this high-speed run here, this shows where in the UK people are settling. So I think just to note that London's sort of sitting somewhere sort of towards the middle of where asylum seekers and resettled refugees are in the UK. So that's a quick flying bit of context from me. Read that at your leisure and give thought to what that means in the personal stories that lie behind it. Next, I'm turning to Helena, I think, to speak about the Council's response.
Thanks very much, Adrian. Very interesting stuff. Next slide, please, and skip again. Thank you very much. Adrian's already touched on the different definitions for refugees and asylum seekers, and I think for the purposes that we're discussing today, it's really to delineate the support that each stream receives, and it's quite a difference between the two. We have asylum seekers who are awaiting the result of their application, and they're mostly in hotels and temporary accommodation. And depending on the type of accommodation, they receive between £8 and £40, and this is to cover essential items. It could be for transport to health appointments, it could be hygiene items, food. So as you can tell, this money really doesn't stretch very far. People who have arrived as refugees normally do so through government programmes, or they've had a successful asylum application, and there's varying degrees of support available, and that's starting to come up quite often in conversations we're having around resettlement versus asylum versus sponsorship, which we're seeing with Ukrainians. And we are pushing the government with the help of London councils to try to bring more balance between these programmes to make it slightly fairer for those who are arriving. Next slide, please. So since August, Lambeth Council has set up the Asylum Support Service, and it really brought our focus to those who are in hotels in Lambeth as asylum seekers with the arrival of the Afghan refugees. And despite these being two different cohorts, it brought to focus the impact of people languishing really during this application process. So the positive news is it's a perfect example of partnership working. We have meetings every Monday. Myself, healthcare colleagues, our schools admissions officers, the HIT team play a huge role in this, and it's been a really constructive partnership, being able to unpick some of the blockages that people are facing, at least with their accommodation, if not their application process. So I act as a coordination point between the different agencies, so between the government, and we're seeing Department of Levelling Up Housing Communities playing more of a role, and the Home Office staying in their own lane, with the accommodation providers and voluntary sector group as well. And we've even had a really successful partnership with Metrobank, who we approached for support with bank accounts for people, and we happened upon a very enthusiastic team who were hoping to go much further than that, and we're now talking about how we can leverage their commercial partners and their commercial clients to maybe provide more support, and that could be from laptops to sports clothes to people who came to the country through similar routes and are now business owners. So that's been a great resource to tap into. We've been working with our schools, and we are able to provide some funding from a very modest budget for school uniforms and PE kits, school bags, and all the bits that you would need to have a good start at a new school. We are looking at ESOL placements, and we've been able to secure additional placements at Morley College. We have a school admissions officer who has been fantastic in expediting the school registration process. So there was a little bit of a backlog when one of the hotels first opened up, and we've been able to speed up that process and get children into school, which is obviously a help to all the family, not just the children. We have an extensive activity programme that's always growing by the week, and it's about linking people into those opportunities where we can have the organisations who are running these services to come along and accompany people on their first visit, make sure that they're settling in nicely. And another item that is a big focus for us just now is pursuing Borough of Sanctuary status through the City of Sanctuary organisation. So we've had initial calls, and that will be kind of longer term process, but a focus for 2022. Next slide, please. The other cohort we have, in addition to asylum seekers, are resettled refugees. Lambeth has a commitment to resettle a certain amount of refugees by 2025, and we've already surpassed our commitment on resettling Syrian refugees, and we're now in the process of finding more permanent homes for Afghans who are currently in bridging hotels. We don't currently have a bridging hotel in Lambeth, but we do have Afghans who are in the asylum hotels. We obviously take the rehousing and resettlement of refugees into consideration alongside the needs of current Lambeth residents. It's a challenging task, but we have our processes in place to make sure that everyone has the appropriate access to housing. Next slide, please. As you can see, these slides were submitted a week ago in time to make it for the agenda, and there's been quite a lot of movement on the Lambeth side of things as we stand up our response to those arriving from the Ukraine. However, we are still awaiting a lot of information and details from government, which will inform how we respond. So as of Sunday, there was 8.6 thousand Ukrainian family visas issued. Local government has quite a limited role in supporting that scheme in particular, unless we're given further updates and requests. But we're very much involved in the Homes for Ukraine scheme. So we're currently in phase 1, and these are known matches, as Andrew Ayres referred to previously. And this could almost be seen as a bit of a pilot scheme and getting processes in place before we receive larger numbers we expect through phase 2. I'm sure you've seen in the news that there have been some challenges around people accessing and submitting applications. So we're hoping to receive further updates on that as soon as possible. One of the areas where the local authority will be responsible is around providing checks. This will include checks on property, on welfare and safeguarding, but we've yet to find out the detail on what constitutes a property check, who can fulfill that, what happens if the property isn't adequate, and the safe goes for safeguarding. We've had an update to understand that there will be funding available for education. It's a sliding scale through early years to secondary education, and we're also awaiting updates on healthcare funding, which I'm sure this forum will be very interested to hear. Next slide. I think I'll probably pass back to Adrian here. Thank you.
And just as another kind of observation on people who are coming from the Ukraine, I think the expectation is that will be largely women and children or elderly, so people who are not staying behind to fight in Ukraine. But I think the other thing to consider is that actually the health system in Ukraine has not only suffered from the warfare over the last few weeks, but actually has a long history of, I think, with damage to the health and system within Ukraine over years leading up to this. I think largely loss of respect for international humanitarian law, and we clearly have seen evidence of hospitals and other facilities being bombed and atrocities such as that. Moving on, just to give, and I recognise this looks a little beyond Lambeth now, but just to give a little bit wider context of the response of South East London. There are other asylum services being offered in other boroughs within South East London, both in the initial accommodation and the other contingency accommodations as mentioned. Next, please. And I think you've heard already about the Afghan resettlement scheme, and again, this is just giving from a slightly wider perspective across South East London of what has been done and the kind of the reasons behind it. And so not to forget those services to particular groups that we're meeting already. Next, please. I think looking at the inputs, and you'll hear more shortly from the health inclusion team, but there are a range of specialist services to support. We'll conclude with saying something about general practice. Before that, you'll hear about the health inclusion team. We also have significant support from the mental health, so unsurprisingly, people fleeing persecution or war or other reasons to leave their homes are very likely to have suffered significant trauma, and that is likely to be a continuing thing, and the support therefore for mental health services is a crucial part, both from our local statutory services but also from a number of voluntary services around London, although many of these are becoming very difficult to access now because of the demand already placed upon them. You'll see, obviously, we have a long history working with the Refugee Council, established actually for a long time in Brixton. Next slide, please. And I think one of the things usefully working across South East London is to generate a clearly sort of understood and then delivered core offer to people coming to the UK. And so the kind of things that this would include is trying to standardise an approach to assessing people's needs, a kind of comprehensive assessment of health and other needs, and then what services we are providing, what can be expected as a core offer that should be available to everyone, and trying to kind of even up any inequities that we may have between different bits of our geography. This is working kind of collaboratively, and I think all of this is joint working, and I think the importance of doing that. And obviously we heard earlier about data sharing, the concerns about data sharing, but also where it's important to do data sharing and information sharing well for safety and high quality services. Next, please. And so I think handing over now to Shazia for Health Inclusion Team.
Hi there. So I'll just introduce myself again. Thank you. My name's Shazia Munir. I'm a GP and I am the clinical lead of the Refugee and Asylum Service part of the Health Inclusion Team. And I just wanted to say thank you to Adrian for asking me along and just an opportunity basically to tell everyone about some of the work the Health Inclusion Team does. So as Adrian says, we are a specialist service. The Health Inclusion Team is part of Guy's and St Thomas's Hospital Trust. We're a multidisciplinary community-based team made up of specialist nurses, occupational therapists, specialist paediatric nurses, health visitors, caseworkers, health navigators, GPs and administrators working in the community. And the two main parts of the Health Inclusion Team are the homeless service and the refugee and asylum seeker service. So I'll obviously really focus on the refugee and asylum seeker services. We cover Southwark as well, but obviously for the purposes of today's meeting, it's obviously most important that you hear what's happening in Lambeth. So the Health Inclusion Team, this is just a couple of slides on the services that we do provide. The very first one I'm going to mention is the Health Inclusion Clinic at Pavilion Medical Centre. So that's obviously a partnership working, the Health Inclusion Clinic working in partnership with a local GP practice. And this clinic provides specialist primary care services in a multidisciplinary team for destitute or homeless refugees, asylum seekers, refused asylum seekers, undocumented migrants, and anyone who has no recourse to public funds. And the criteria really are people who really have struggled to access any primary care. So people get picked up from the homeless team, from day centres, from charities. We mentioned Refugee Council. And the idea is that we see them for a short term, and that, because obviously people should be able to register with their local GP, but we're able to provide specialist input until they're able to register with the local GP. Now, Helena, the second part of that service, Helena mentioned the resettlement programme that Lambeth have been doing a lot of great work on. And because the Lambeth were aware of the expertise that the Health Inclusion Clinic has, we actually did all the, and are still doing, all the initial health assessments for any newly arriving refugees on these resettlement programmes. That's the Syrian resettlement programme, also children who come on the Vulnerable Children's Programme, adult programmes, and the few families that have come on the Afghan resettlement scheme. And that has been very good because they have a comprehensive assessment and then they're registered with a local GP. So it's been really useful for local GPs as well to know that those newly arriving refugees have had a full assessment. So that's the Health Inclusion Clinic. Another, we sort of scope Lambeth as part of our work, and we'll pick up sort of and charitable organisations or day centres where it's appropriate for our team to go. And somewhere where we have been going for a long time is Streatham Day Centre. This is a day centre for refugees and asylum seekers and homeless people. And one of our nurses and our caseworkers go there and provide support and advice to refugees and asylum seekers. The next slide, please. So Adrian and Helena obviously mentioned the situation with the contingency hotels that have emerged in the last few years. There are currently 2 initial accommodation hotels in Lambeth and 4 in Southwark. I will talk a little bit more about that on the next slide. But our health team is providing outreach health services to asylum seekers in some of these hotels. Our health team has also been working with GSTT vaccination programme to deliver COVID vaccinations to the population who struggle to access that from other routes as well. And the team also is a specialist service, so we work in partnership with organisations to develop specialist pathways for refugees in the area, and that's across a range of antenatal contraception, mental health, and also specialist advice and support across South East London. Next slide, please. So we mentioned the hotels. I know we're mainly talking about Lambeth. There are 2 in Lambeth and 4 in Southwark. And the team has been commissioned to provide a group of nurses, health visitors, paediatric nurses to go into in-reach hotels and provide, as Adrian mentioned, it is a group of may struggle to access health and access. So outreach work is crucial in ensuring people have equitable access. Just spoken about that already. So next slide. And I think this was just an example of some of the work that the team can do within a hotel setting. So actually going in to see face to face. So actually helping with assisting with that GP registration, which we know is crucial. The team also work to make sure all the children that are in the refugee living in the asylum seeker homes actually get access to school and help facilitate that. Complete initial health assessments, manage some complex cases. So this health navigator role is really important. If people don't speak English, they don't know the system, they've previously been in a situation where they may be scared of places where they've seen people in authority. It's about helping get those people make their way to their appointment, make sure they have interpreters and make sure they're applicated. The team are also able to do some things in outreach that would then save the GPs restrictions, do some appointments, can really keep a close eye on those with higher needs, so the pregnant women, those checks, and also help with the perception and managing outbreaks. So obviously being in a hotel setting, there will be outbreaks of some infectious disease, and basically signposting patients and catch up in patients. So that's really sort of in a nutshell what the team in Lambeth. I mentioned Southwark. It's just, I think it is important to know what our neighbouring boroughs are doing, but they do have 2 Afghan bridging hotels, just for awareness, and also our core home office initial accommodation is there as well. Next slide. And Adrian, do you want me to just touch on this while I'm here, or do you want to talk?
Yes, I think give an introduction, and I'll say a little bit more about the specialist and the sort of general.
So it was just to say, obviously, as a health inclusion team, we work work very closely with general practice, so particularly in the hotel setting, the patients will be registered with their local GP, and that's very important. There are practices that are supporting those.
Sorry, Shazia, can you say that again? I think your microphone boom isn't working well.
My terrible microphone. No, I was going to say.
We'll have to have a wait round for
no,
them.
I would say the health inclusion team work very closely with the local GP practices. So obviously the people living in the hotels should be registered with their local GP, and there are GP practices who are working with those people, who are registering those people. So thank you very much.
Yeah.
Thank you. I'll just say a little bit more about the sort of the mainstream general practice offer here. So as the slide says, we currently have 5 practices supporting 2 venues within the borough, and just the things that become apparent, the complexity of trying to get things right. So clearly everyone should be getting registered practice, and I think important that registration is full registration, not temporary registration, for continuity of care, and the reality that most people are going to be spending some time accommodated locally before moving on into either dispersal accommodation or one hopes at some point permanent and secure accommodation. Amongst the challenges of doing that, so we have support and the people who've arrived locally are given support with registration from both hotel and health inclusion team, but the kind of tricky things you work out as you go along are trying to see that actually a family, all members of a family are registered in the same practice, seeing that people can have access to all the services through general practice that they should expect, and then obviously specialist services as needed, then obviously referral into secondary care as appropriate. I think the other thing is doing some special sessions. So I think both in the generic general practice offer, but also within the specialist team offer, seeing that people have the vaccinations that they should be doing, often including catch-up vaccines, screening for health problems that people may have brought from their country of origin, so an awareness of the kind of particular needs depending on where people have fled, and trying to make accessible clinics, doing joint clinics and trying to get people together for things such as health checks and vaccination services. Next slide, please. I think all of this is in the context, I think, as we said at the start, and I think to conclude, there's a massive amount of joint working here, and I'm pretty certain that just in the kind of, didn't quite do it as a pretty word cloud, but just listing some of the component parts of the offer, I'm sure I've upset somebody by forgetting a service on that slide, but I think, this is massively complex, massively important, and absolutely requires the joint working together. I think frequently with a trauma-informed approach to people's needs, and to trying to bring some sense of safety, security, and good health and care to people who've had some of the most appalling histories of how they've come to be where they are now. I guess the last thing to sort of leave people with is just sort of what can we do beyond the things that we have described here. So I think what we're describing here is what we try to do jointly as a system, Lambeth together and with a wider geography as well. But what else can we do? I think this involves politics. I think it involves money. I think it involves support, and clearly the response that we have for different waves of people coming to this country, so most notably at the moment from Ukraine, and the response that we see, and what more response that we can plan, given the the particular needs and the enduring needs of people who find themselves in the circumstance of being a refugee or an asylum seeker. So thank you for your time, for listening to us, and I guess open up for conversation. And if there's anyone else who is providing services who has not had the chance to kind of contribute, then would be lovely to hear from you, or any questions or comments, please.
Thank you, Adrian, Shazia and Helena. I think that was a really comprehensive overview of the system, the support system that envelops asylum seekers and refugees in our borough. And I particularly value the fact that you re-emphasise that this is basic human rights. In terms of confidentiality and where our hotels are, there was a little accident earlier which we're going to take out of the video. Can I ask all board colleagues and attendees to the meeting not to share what you might have heard, just to make sure that we keep the confidentiality of those residents. Now, I'd love for everyone to kind of put their camera on so that we can start our discussion. Does anyone have any questions or points for the team? I might ask you first. No, actually, I'll let Sue go first, and then I think it was Jim that was next. Oh, I got it the wrong way around. Yeah, go Sue, while your voice is still with us.
Thank you very much for a very compassionate and impressive presentation of a very tragic situation. I had 3 questions. I don't know who to direct them at, so perhaps you could decide how to respond. But one was, could you give us a feel about, say, how many people in the last 6 months or the last year, or if it's changed a lot, the sort of volatility of the numbers that are of people that are supported by the Health Inclusion Clinic, and whether that does fluctuate wildly across the months, or whether it's just steadily increasing, or how you manage demand and how you can flex towards demand increasing or decreasing. That was the first question. The second question was, you mention in your list of the many involved organisations volunteers, and I know that there are masses of people responding to the Ukraine situation, but I also know that there are a lot of people who would like to know better how to support refugees and asylum seekers that are currently in Lambeth, if there are ways to do that in a befriending way or in some organised system. And I wonder if you could direct us to who to go to get more information about that and the sort of support that is useful and or desperately needed. And the third question I had, which I'm asking really on behalf of the more sceptical members of the public, perhaps, I don't wish to include myself in this, but when you look at the slides and you see where people end up, there is a predominance towards the northeast and Yorkshire and not the south. And I wondered how you manage the process, or how the process affects you as caregivers when people do eventually get to the end of the process and are told that they hopefully can be resettled, and then are told, but where do they go? And they get potentially, I don't know whether this is how it happens, get placed a very, very long way away, and how we help the transition that might involve.
Thank you, Sue. I'm going to take some more questions and then we'll try and get the answers. So Jim, if you go next.
Yeah, just really quickly, I thought it was a great presentation, and it absolutely sort of fits within the approach that we've had in Lambeth for many years of having a sort of proud tradition of welcoming refugees and being prepared to ensure that the public services are there to support them. So we can, and I think I'm right in saying that for this Syrian refugee cohort that came to this country, I think we agreed as Lambeth to take more than any other borough in the country. And we also had at least one local community group who put their efforts together with support from the council and did community sponsorship of more than one refugee to settle in their community. I'm happy to say it was Herne Hill, which I represent. Herne Hill Welcomes Refugees, incredibly successful local organisation who were able to welcome 2 families now to their community. So that's very much where we come from, but none of that would work if we didn't have the health support infrastructure that's been set out. So it absolutely welcome all the work that's been done by the health inclusion team and by other parts of the health system as we go forward. I did ask one of our officers in health and social care in the council to have a look at what the additional costs that we experience as a health system in Lambeth amount to, and whilst it wasn't possible to arrive at perhaps a single stable figure, but clearly there is a cost, and I would just be interested to know what work we've done to see whether any of that is recoverable from central government. Not that we would make an inability to recover it a reason not to continue with the work, but clearly it is expenditure in our health system to support vulnerable people who often require more health support than the rest of the population. It would be good to see whether we are able to ensure that we are getting our costs recovered as far as we possibly can. So just be interested to know what work is going on, 1, to identify the cost, and 2, to think about cost recovery.
Thanks, Jim. We've got 2 more questions and then we'll let you answer. Raj.
Great, thank you. Great, you're doing great work, Adrian and the team. Over your many years of learning and working with refugees, what has made the biggest difference in their lives in terms of making things better for them? And how should we in the health service, you say that we should have a trauma informed approach. How widespread is that, you think, in terms of Lambeth practices, and how can you help us with the learning from your work? Because every practice has refugees, but I think that the training that you mentioned and the way to deal with people is a very specialised skill, and I think one of your ways that you could make your experience more widespread is to sort of help us with that learning. Thank you.
And then one more question from Lucy.
Hi everybody, thank you. I was looking at the figures about where people are resettled, and because it's about a number per percent, it's a percent of the population, which I think rather skews things. So I put my hand up while that point was being raised, because obviously London and the southeast has a bigger population than the northeast, so that the actual absolute numbers might be bigger, but I don't know because I can't find that in. So some comments on that. And then my other point was about sort of building a little on what Raj was saying about post-trauma. Years ago, I was involved in a project at Vauxhall City Farm, which was a group of Bosnian people that had fled the conflict in the Balkans and were being treated at SLAM, and they did a gardening project together. So it was the beginnings of my belief in interventions beyond sort of traditional healthcare, and the gardening, and that sort of supported them to kind of grow vegetables and work in different ways, and it was incredibly inspirational. So I just wondered some comments on the involvement of our local voluntary sector in supporting people would be interesting. Thank you.
Thanks. So Adrian, were you taking notes through all those questions?
I was. I think I've captured them all. So should I just try and sort of hand them out? So I think Sue's questions. I think the first one about numbers, health inclusion team, clearly to Shazia. I think the volunteering thing, I would suggest to Helena, and then I can try and say something about Sue's third question. So should we go in that order for the first round? So Shazia and health inclusion team numbers.
Hi there. So sorry Sue if I've forgotten the whole question. So I think the question was about numbers that the health inclusion team see and whether there are fluctuations. Yes. So I can't give actual numbers off the top of my head. As you saw from my slides, we've got multiple different parts of our service. So you know, it would be difficult for me to sort of put that all together. But what I would say is that I know, you know, what isn't necessarily included, say, in the Home Office figures are those other types of migrants, you know, other types of, you know, people that I mentioned. So there's also undocumented migrants who haven't put a claim in. There's people who are refused. There are people who are asylum seekers but don't seek Section 95 support. So actually, if you look at the Home Office figures, I'd say in Lambeth and in London, we probably have, as Lucy also sensibly pointed out, in terms of the ratio, I think we've also got to be mindful of that sort of unknown population we have. And we certainly see that in the Pavilion Clinic. So people who have got no recourse to public funds, who haven't put an asylum claim in because they didn't know they could, or who have, and the process is so long that they get knocked out at various stages. So I think it's difficult to put a number on. That hasn't really helped answer your question. I don't know. And I think politically, you know, you'll have episodes where you'll have the Syrian resettlement program, the Afghan resettlement program, and now with Ukraine. But as Adrian said right at the beginning, conflict, unfortunately, in the human world is always present, and this is not a new problem. And people are always going to migrate and flee for various reasons. So I think there will be slight fluctuations, but I'd say there's always people that need to be seen. They just might be hidden.
I can do a quick supplementary. I think you've recruited some more staff recently. Helen, do you want to say on volunteering?
Yes, thank you very much for your question, Councillor Kilcott. We have regular engagement with voluntary sector groups who are active in this area. We meet every 6 weeks, and I think they're finding it a very helpful platform, and they are very content that the council is stepping even further into this space. It's important to us that we don't create any dependencies. So it's very much about complementing the existing work that's been done, and the voluntary sector have been very active long before we've come along, so making sure we give a nod to that. And as for the going beyond just healthcare, there's 2 streams to that. So there's the activities that voluntary sector groups are standing up themselves, and these are as varied as you could possibly think. We've got pottery, we've got boxing, but also with money that has been recovered, and this touches on Councillor Dixon's point, money that has been recovered from the government through the CCG that is being allocated to well-being in general, and that could be previously it's been applied to things like gardening, funnily enough, that you mentioned, but we're also looking at cooking courses and looking at well-being in a much more dynamic way, and how this could lead to improved mental health outcomes. If there's any further questions, let me know.
Thank you. And I think that the third question, Sue, about where people end up and how, I think to summarise, I mean, you know, there's a process with a delightful name of dispersal. I think, I'm sure, driven to some degree by availability of accommodation, but we also hear suggestions that accommodation might start to be in old military barracks and things like that as short term. So I think it's probably a question that the Home Office is better able to answer. I think what we do recognise is that people may be dispersed, who then make their own way back to places where they feel more comfortable, and where there are communities that they would feel more comfortable within, as a general observation. Shazia, do you want to add to that?
Yeah, I was just going to add from a sort of healthcare perspective, one of the problems with this dispersal process is obviously someone will have a full health assessment and have everything checked, and then they'll move and that won't go with them. So there's a lot of work being done on a health passport at the moment, so that moves with the patient. Yeah, so that is a really important point, and that this sudden movement is very upsetting, I think, for individuals once they've sort of settled, and it does make it very difficult for people to settle in an area if they know that they might move.
Yeah, I remember years back when I was actually working as part of the health inclusion team, or well, maybe in 3 boroughs back in the day, actually visiting and speaking to people in a hotel who were fearful of the arrival of the coach that was taking them somewhere later that day.
Gosh.
Uh,
We've got one more question in the chat from Livia.
Shall I just
from
quickly do
Thrive.
Yeah, and
Yes.
I'll try and pick up Livia. Jim's question, I'm not sure that we can answer here, but yes, the funding things, clear to pick up. Raj, I think, yes, a very important bit. I think if you had to say what's the most important thing, probably being a bit of an old hippie, I say being kind, is just treating people with kindness. Probably trumps almost everything else. But I think there are specific things, and actually, particularly in the homeless field, quite a lot of training available on trauma-informed approach, and that may well be, as you suggest, something we should spread more widely. I think the other question, I think we picked up a bit about Lucy. I think you've made the point about the numbers, and yes, happy to look into that more. So I've taken some sort of headlines for the purpose of today, but relative versus absolute numbers of where people are located. I think the other observation about what people do and what's helpful. I remember years back. I think I can probably safely say it now because the hotel's long been demolished, but a hotel up near the Elephant and Castle, where actually probably the most therapeutic intervention there was a football team that made up of people who were living in the hotel. And then I think the last question that came in the chat, Livia, so I think sort of the question there is asking sort of breakdown more by ethnicity and country of origin to understand more sort of what happens to people, and is that determined by where they've come from or what they look like? And I think that's a fair question. Obviously, our focus on inequalities throughout all that we have done, I think that's a fair question to ask, and I think we can try and find an answer for you.
Thank you, team. That was superb, absolutely superb. Thank you very much. We look forward to keeping in touch with what's happening and developments. Yeah, that'd be great.
Thank you all.
So I think I'm going to step away from chairing for the next item, because the next item is to do with primary care commissioning. So I'm going to hand over to Jim and switch my microphone off. So
Thank you, Di, and you're one of a number of people on the board who have very appropriately declared an interest in this item. We are looking at, as a board, we're looking to endorse 2 items of primary care commissioning business. And I'm going to ask Gary to give us an introduction, and then we can ask questions and make comments before we move to a decision. So, Gary.
Thanks, Jim. So I know I said it earlier, but just in case you weren't here for that, I'm Gary Money. I'm Director of Primary Care and Transformation for the CCG in Lambeth. So from that fantastic item that we've just had, I'm afraid we're into a bit of governance and keeping the wheels of business turning, which is obviously another core part of our role in this board. I think we probably haven't taken during the pandemic a lot of primary care commissioning business through this particular board. However, if some of you have seen our sister committee, another prime committee of the CCG, which is the South East London Primary Care Commissioning Committee, that also meets in public. And essentially what you have in the pack today is a little cover note from me, but essentially it's the paper that was actually presented in public at that committee earlier this month. And you'll see it's a bit circular in that it references coming to this board multiple times. So do bear with me as I try to just very simply, hopefully, set out what this is. So as I say, there's a short paper in your pack. It basically concerns the governance around some decisions that we have had to take about continuation of some specific services that we've commissioned in Lambeth for primary care. There are 2, as Jim said, types of service, so therefore 2 decisions. One concerns our extended access hubs, which hopefully people are broadly familiar with, and I am happy to elaborate, but just in simple terms, these are a number of locations throughout Lambeth that offer additional general practice appointments, GPs and nurses, to anybody registered with a GP in Lambeth. And in a typical year, they deliver somewhere between 50 and 63,000 appointments. So they're very busy, and an awful lot of the population at one point or another will have been to one of our extended access hubs. The reason for this specific decision is that we had a contract with our GP Federation who've delivered a fantastic service over the years. That came to an end at the end of this month. It was deliberately timed in that way because NHS England have been negotiating a brand new model of extended access due to be rolled out across the whole of England called enhanced access. And we've only very recently had some details about that, which I dare say is a good topic to bring back to this board once some of that work has taken place. But in simple terms, the new arrangements are delayed and will now not take effect until the 1st of October in terms of transacting that new model through primary care networks directly. Because of that, we've had to issue a new 6-month contract to the GP Federation, and essentially the decision is to issue a new 6-month contract, and we're seeking the endorsement of the board that it was appropriate to seek and secure a tender waiver, which is what the CCG has done, basically for the reason that we don't believe this service could be delivered by anybody other than our local list-based general practice service that's integrated with the other 41 practices. Also because it's only for 6 months, so it would clearly be massively disruptive to all local services if we were to try to do a full procurement and try to change provider potentially. So that's the first decision concerning the extension of our extended access hubs until the end of September. The second one concerns, and there is a description in the paper which is rather dry, but I'm again happy to elaborate about what a local enhanced service and a local incentive scheme involves. And again, very shorthand colloquialism. One is part of the GP contract and one is supplementary to it. One has to be via NHS England and one is allowed to be commissioned locally via entities such as the CCG. And it is relevant to the last discussion because one of those services is our homeless and asylum seeker local enhanced service, which a couple of our practices, as you saw earlier in the slides, deliver. In this case, we have not even sought a tender waiver. We've taken advice, and we, because these services are intrinsically only general practice, and as I say, either part of or supplementary to the GP contract, we've taken the decision to continue these contracts into next year. It's something we do every year, but I think what we wanted to do as part of the CCG evolving into the ICS is to just do a bit of a check of our own governance. So I think this is very much about bringing to the board's attention and seeking your endorsement that we follow due process and that this is a decision that has some merit. So beyond the, and I can talk a bit more about the schemes themselves. Beyond that, just to sort of summarise, Jim, was that in terms of seeking endorsement from the board, this is about the board acting as a prime committee of the CCG governing body. So it is written into the terms of reference as to how this will work. It is within the standing financial instructions of the CCG as a partner within this Lambeth Together Care Partnership Board. But I suppose as we're evolving, and obviously we're now meeting in shadow form with our new co-chairing arrangement, it's also a sign of intent, I think was the other point I was going to make. So we are bringing it here for a decision for endorsement of these two particular bits of business. But I would hope that this is the beginning of a bit more of this kind of business coming to this committee. And I dare say all of the different organisations, not just the CCG within the partnership, will be reflecting upon how we can do that. I think it helps to kind of raise the transparency level. And clearly, whilst it's been at the South East London Primary Care Committee, this is our local place-based partnership, and clearly most of primary care is delegated to place. And so I do think it's appropriate that if you remember, those of you back pre-pandemic when we had our, so I'm looking at Sue, you know, our previous Lambeth CCG Primary Care Commissioning Committee in public, we used to do a lot of this kind of business in public, and we had very good attendance. And essentially, this is a little bit of a return to some of that. So hopefully more to come. But for now, probably I'll leave it there, Jim, in terms of the very specific endorsements that we're seeking today.
Thank you very much, Gary. That was very clear, and I think it's sort of fairly clear what sort of decisions we're making and how we need to make them. So questions, comments at all? I've seen Sue.
I apologise, Gary, if I wasn't listening carefully enough, but is there a reason why we can't just extend the extended access to the end of the year? It seems a bit mad to extend it for 5 months only. well, maybe it's 6 months. I'm not sure whether it's the beginning of September or the end of September. But presumably there is a reason why we can't. But wouldn't it be more sensible to extend it to the end of the year?
There is a logic to doing that. I think you're right. At the moment, NHS England have essentially told us that from the end of September, and bearing in mind this has now been delayed twice nationally, that they've said there'll be no further delay, and that essentially the funding that comes directly to the CCG that enables us to hold this contract with the GP Federation will no longer be there. Instead, they intend to transact it from the 1st of October directly as a payment to primary care networks, who obviously will be doing some design work, as I say, bringing it back here, but basically they will then be determining how they deliver the new specification collectively, including what the role of the GP Federation will be. So it's on that basis that it doesn't go beyond the end of September, because we've been told we will not have the funding directly.
Thank you.
Thank you. Thanks for that question, Sue. Any other questions or comments on this item? Clearly, it's been discussed in detail elsewhere, and we're seeing it here for our endorsement and for noting. If there aren't any other questions or comments, can we endorse and note the decisions taken on these schemes in Lambeth for 22-23?
Agreed.
Thank you very much. I'm going to hand back to Di.
Oh, I'm back. Thank you. Right, let me just get my agenda up. So our next agenda item is on recovering and living with COVID-19. We've got two presenters. We've got Sophie Taylor and Tom Barrett. So I'm going to welcome them in to start us off. Sophie, do you want to start first?
Yeah, sure, I can, if that's okay with you, Tom, and then hand over to you. Thank you. And for those of you that I don't know, my name is Sophie Taylor and I'm the programme lead for Lambeth Together. Before Tom takes us through the detail of the impacts of the new national guidance on living with COVID, just wanted to take us through on behalf of the board the review that the Lambeth Together partnership has undertaken over the last few months to reflect on where we are as a health and care system at this point in the pandemic, which we've done by revisiting our 18-month strategic plan, which was published in September of 2020 and called the COVID-19 Health and Care Recovery Plan. You will find this review of the plan on page 63 of your pack. In order to review this plan from 18 months ago, the Lambeth Together Delivery Alliances, so the Living Well Network Alliance, the Children and Young People's Alliance and the Neighbourhood and Wellbeing Delivery Alliance, as well as our Equality, Diversity and Inclusion subgroup, our acute trusts, and our priority programme areas of sexual health, homelessness, learning disabilities and autism and staying healthy, all reviewed the actions and risks that were set out in the original strategy for their respective areas. And then as a Lambeth Together partnership, we've reflected on where we are and what's been achieved over the last 18 months, as well as the challenges that still exist. As well as this, it was also taken as a bit of an opportunity to snapshot the achievements and activities delivered to date. And I think, Sue, you mentioned this a little bit earlier in the public forum, and there's perhaps some more detail to come on this in future, but some of which weren't actually even mentioned in the original plan, such as the vaccination programme being the obvious one. And we also wanted to consider the change in the environment in which we're now working. In conjunction with reviewing our activities in relation to kind of managing COVID, everything from the surges to vaccination, including how this will be changing going forward, the review has summarised the findings and allowed us, I think, as a partnership to reflect on the wider learning and opportunities which the board has considered collectively, and identify what still remains relevant and what our focus should be over the next period. So it's really important, we think, and we hope that we'll come to this in the discussion, but that we will agree today that we now share this review with our residents, which we would like to do and to make publicly available and share with the public from today onwards. The learning and next steps set out in the review will ensure that we continue to progress our strategic priorities, which we all know well, but are to integrate care, improve population health and tackle health inequalities without losing sight of some of the innovation and opportunities that have actually been presented during the pandemic, but also noting that there are a number of challenges, some of which were there before and some of which are new, and that those will still remain. And probably, as we've been talking in some of the other areas today, we will find new challenges come along as well. So just to summarise before Tom comes in, the review, if you like, is our context for which the changes in guidance recently announced, which will kind of inform how we will manage the virus and live with the virus within them will operate. So I'm sure we'll discuss this further in our discussion section for the item, but we just wanted to kind of set that context and the review as that context before moving on to the detail. So I'll hand over to Tom to take us through that.
Thanks, Sophie. Could whoever's holding the slides nudge them on, and one more, please. Lovely, thank you. So I'm Tom Barrett. I'm the AD COVID response in the Council's public health team. And I've just got a few slides here that take us through the government's strategy, COVID-19 response to living with COVID-19, which was published about a month ago, and followed by kind of a number of announcements by the Prime Minister. So this was the strategy that set out the government's objective to enable the country to manage COVID like any other respiratory illness. They set out 4 broad principles for the strategy. These are underpinned by population immunity conferred by vaccination and infection. And they are broadly what they describe as living with COVID, which is the removal of all the restrictions, public health messaging around safer behaviours and so on. A section on protecting people most vulnerable to COVID. So this is about vaccination, targeted testing, addressing health inequalities. A piece around maintaining our resilience. So this is around ongoing surveillance and contingency planning, and a bit around securing innovations and opportunities, some of which we've just been referring to in terms of the recovery plan, but from the government's perspective was more about some of the national infrastructure that they put into place. So I'm just going to go through in the next few slides some of the areas where there's been an impact. A lot of this will feel like old news now, but I'll just go through quickly kind of where we are. So as we've already had plenty of questions in the public forum around testing, the majority of the testing infrastructure is going to be removed from the 1st of April. There are going to be some mobile testing units available nationally should there be outbreaks, but broadly LFDs will become charged for. So this is the lateral flow devices. It looks in terms of the care home guidance that visitors to care homes are still going to need to demonstrate a negative test to visit care homes. And it's fairly clear at the moment that that's not going to be funded. So as in terms of kind of impact in the borough, what that means is the fixed testing sites that we've had in Streatham at Wheatsheaf Hall and at Angela Davies will be removed. Angela Davies had already closed down and been replaced by a mobile testing unit in Windrush Square. But all of our mobile testing units will also be removed from the 1st of April. If we go on to the next slide, please. Contact tracing. So our contact tracing approach, we had a local approach to our contact tracing, which was exceedingly successful, both in terms of kind of the quality of the service we were able to provide residents and the benefits of having a local approach. But that's been closed down now since the 24th of February. And we have been redeploying where we can our contact tracing resource into other areas of the business. I know some of them have been helping out with the Live and Well Network Alliance, and a number of them have now stepped into roles supporting the Ukraine refugee response. But essentially, there is no longer any contact tracing. It's as kind of straightforward and as cliff edge as that. We had three or 4 days to shut that down. The next slide, please. So along with the contact tracing closing, the requirement to self-isolate following a positive test was removed and replaced with advice to self-isolate. And with that, there was also the removal of the support that was in place for self-isolation. So there was this statutory and kind of discretionary self-isolation support, and then we had additional self-isolation support that was in place in Lambeth. And there's been quite a bit of conversation on the chat already about the household support scheme. So because the self-isolation is no longer a requirement, all the funding for that disappeared. But I think what we'd be encouraging residents to do is, if they are facing financial hardship as a result of having to isolate, or if they're faced with the choice between either isolating or going to work, we'd prefer them to isolate, and they can access their funding through some additional funding through the household support scheme. And by the looks of things, we'll be able to keep that funding going, given the Chancellor's announcements earlier on today. On vaccination, I think Gary's already talked a little bit in the public forum about the vaccination programme, but the announcements that were made last month essentially set out the acceptance of the advice for 5 to 11 vaccination. That's a programme that's going to be starting from the 4th of April through community routes only, not through schools. And they also accepted the advice around what's now being described as the Spring Booster campaign, which started at the beginning of this week, or at least access to the national booking system and so on started this week. So obviously we're engaging as a system in the delivery of those programmes, whilst maintaining what's described as the evergreen offer, which is those who are still wishing to come forward for their first dose. In relation to responses to outbreaks, I think again we had a conversation in the public forum about the powers of the DPH, but of the Director of Public Health, that is. But largely the additional powers that were provided to the Director of Public Health as a result of COVID-19 were removed from the end of February, and all of the guidance will be completely removed from the 1st of April. So some of this relates to health and safety requirements and COVID certification and so on. So this is where things begin to get, well, I mean, there's still quite a lot of areas where we're awaiting quite a lot of guidance, but again, there's a general requirement here that there's going to be a need for regular and ongoing public health communication and advice, but this will be general because we are treating it as any other illness. The government has said it will revise the outbreak management advice and frameworks, but again, a lot of that we are waiting to see. So if we go on to the next slide. The next one, so this Jim described at the end of the public forum, the letter that we've sent out to all residents recently, along with a flyer for the Household Support Fund, setting out the general advice that we're providing residents. So there's the general stuff around getting vaccinated, washing hands, ventilation, face coverings and so on, and then some additional advice for those who are vulnerable or at risk, but that's particularly around encouraging vaccination participation in the Spring Booster campaign and so on. And for those who are particularly vulnerable, they will already have been provided with free PCR kits and kind of emphasising the importance of using those so that you can access treatment options as quickly as possible. If we go on to the next slide, please. So we have had in place since the start of the outbreak, our outbreak management plan. We're now on to version 5. We're looking to have this published from the 1st of April when all the new guidance has been removed, and this will essentially set out how we're going to be protecting residents of Lambeth from the ongoing risk of COVID, given the new guidance. I think the challenge that we're facing with this version of the plan is that we are still awaiting quite a lot of the guidance, and it looks like that wait is going to be going on well into next week and subsequently. But I think our view is that we'll get a plan live from the 1st of April that reflects the changed guidance, and if we then need to produce an updated version quickly, then we will do so. And I think there's one more slide. So yes, so the Association of Directors of Public Health in London did an exercise recently where they discussed a couple of scenarios for the route that the pandemic is going to take. So this was kind of the decline and transition, or the significant escalation kind of routes. And they posed some of these questions to Directors of Public Health, but I think some of them are pretty appropriate for our system as well. So I just thought I'd kind of close these slides on some of those questions and then open up to any other questions that you got for Sophie and I.
Thank you, Sophie and Tom. It's definitely uncertain times, isn't it, when we're waiting for all this guidance, and so I think these questions here are really, yeah, make me feel slightly uncomfortable. What do we need in place to respond again?
And I think one thing I would say, Di, is what we have done in kind of closing down the COVID response team, which I've been responsible for, is as well as having the outbreak management plan in place, we've got kind of what I'm describing as rapid restart plans. So should we need to do what we've described before as kind of surge testing or surge vaccination, or any of these other kind of surges that we might be required to do, that we've got the skills and capabilities retained within the organisation and the plans to be able to kind of take off the shelf to be able to do some of that. So I think that kind of rapid restart planning is one of the things that I think is helpful in this space.
I don't see any hands up yet, so I'm going to ask another question about the workforce that you had to stand down very quickly. Obviously, they've now got they must have a really good sort of organisational memory and new skills that they've taken on board. What happened to that workforce?
So at the moment, they're almost entirely working in various different bits of the council or health system. So they've
stayed in Lambeth.
So we've distributed as many of them as possible, but we had a team of up to 40 contact tracers, expanded so that we could deal with the Omicron wave, who are on flexible contracts, and we don't have the capacity to absorb 40 additional members of staff with no additional funding to follow them. But what we are trying to do is secure them work in other bits of the council or the health system, and we've been working with colleagues to do that. And there is a kind of transition and then a further kind of bit of work where we're looking to retain the skills of both our contact tracers and our testing teams to deliver some of the interventions that we think need to be delivered over the next kind of year or two that respond to the impacts of the pandemic. So kind of addressing health inequalities, supporting the work around the bus and so on. So that's the kind of ongoing bit of work we want to do.
Thank you very much, Tom. Now the hands are all up now. So Penelope, you were quickest. Go ahead.
Thank you, Di. So my question clearly is from a primary care point of view, but I think it will apply in other organisations as well. As far as I know, the infection control guidance has not changed. We know that COVID is still around and still serious. We know that the people who come to come to health care settings, almost by definition, will be the more vulnerable. We are small businesses. We do not want our patients nor our staff to be catching COVID on our premises, and we will continue to be careful, or at least we want to continue to be careful. I'm not sure how much this will be understood outside our services. So I think there is going to be a big issue with communication understanding and expectation. As I say, I'm sure not only for us, but other service providers where we are working with vulnerable groups.
Completely agree on that one. Should we go down to the next commenter, who's Lucy?
Thank you, Chair. I really welcome the sort of planning for the future and retaining the experience that we've had, but I sort of reflect on the fact that it could be some years, you know, into the future before something like this happens again, when we're all, you know, not here anymore. So how do you kind of retain? Human beings seem very, very bad at learning from history. So I just wonder if there's something that we can do to make sure we protect everything that we've learned and sort of keep it for our heirs in the future.
Great. Hold on to that one, Tom, and we move to Sadru.
Yeah, Tom, it was just a sort of general question about whether any of the people that you can no longer keep on might possibly be redeployed into general practice, because we're always looking for people.
That's right.
Do you want me to take all of them now, Di?
Yeah, can do, because we've got quite a few more hands afterwards. Yes, so we'll have another round.
And then I don't know if other colleagues kind of want to chip in. I don't know, Gary, if that's kind of why you've put your hand up as well. But look, Penelope, the point you make about communication and expectations is exactly right, and I'm sure that we will be continuing to kind of get guidance and internal communications from the NHS system, and certainly the decisions that we've been making over the last week or so is to kind of continue with the kind of campaign messaging that we've got around on the high streets of Lambeth and so on, about encouraging behaviours that enable us to continue kind of protecting ourselves. And it's only where those kind of messages are particularly dated, like the ones that talk about testing, for example, that we've asked for those to be taken down, because I just think certainly over the coming months, continuing to you know, push those messages about how we protect ourselves are very important. Look, Lucy, I think Lucy's question on kind of, you know, business continuity planning and kind of how we retain that information, I think is really important. I think part of it is about having those kind of standalone plans that don't rely on people necessarily, but are quite factual, and these are some of the things that we did. But some of the stuff we've talked about in the team as well is kind of actually noting, you know, it's almost some of the stories about how we've gone about things, because I think as time moves on, even when you retain the people, you forget why it was you made the decisions you were making at the time, and it was always because you had imperfect information and things were moving at speed and all those sorts of things. But that's certainly kind of going to be a key part of how we retain that, and I think that's part of the lesson that we have to learn with you know, business continuity. And you know, it's surprising, you know, working with colleagues on some of the Ukraine work already, how many of the kind of themes are kind of common about actually we're being asked to respond, we don't have the levels of information we need, there's issues around data and data sharing, how do we overcome them, and so on. So it almost feels sometimes like actually there's been a collective learning within our system about how to react to that, but I take your point that organisational memory fades. So we'll look into that. Sadri, on the kind of GP side of things, look, I'd be really interested in taking forward any conversations that there are, because we've got a lot of people who've been working with us. Not all of them are local, but the majority of them are local people. They've been working, talking to people about health and care for the last year, 2 years, some of them. And so I think they'd fit very well into some of those roles that you know, that have appeared in the GP contract around kind of link worker type things, and a lot of them have got a lot of enthusiasm to do that. So how we do that, both formally in terms of redeployment, or how we link up those, you know, how we network everything together, is going to be, I think, kind of a key part of how we take our kind of neighbourhood response to health and wellbeing forward.
Great, that would be so exciting if we can make sure that we retain those people in Lambeth. Sadri, your hand's still up. Did you have an additional question? or shall I move to Raj? Yeah, Raj.
Thanks, Di. Thanks, Tom. My question about ongoing resilience and post-COVID, living with COVID. Have we, the system, thinking about, how are we going to help our population to be less anxious and to be able to deal with, because the last 2 years it's really freaked people out. And if I look at my morning clinic this morning, over half of the patients were feeling anxious with symptoms of anxiety. And last Monday, I had 3 kids under 18. First time in 27 years, I had young children who were feeling very anxious. And the staff are tired and been working at full stretch for the last 2 years. What are our plans to help staff in the system to continue working? And what are our plans to help our patients feel less anxious and have ongoing resilience?
Okay, hold that thought and we'll move to Gary.
Yeah, I mean, I'll say what I was going to say, and then I might just very quickly, opportunistically, have a bit of a snap answer to what Sadra and Raj have just said, because clearly some of this goes beyond. I mean, whilst Tom is a bit of an everything man, I think some of this stuff probably does sit with the people
Not be able to fix everything.
Yeah. So what I was going to say is, I think the point that Lucy made is really true. We do have a horrible. I'm going to say it. NHS England also don't always learn from how they have done things before. So there's an awful lot of what I would say is we've delivered some unbelievable things, and the number of people involved in doing just the vaccination programme is absolutely staggering. So there's an event at Westminster Abbey, a thank you ceremony, which is happening very shortly. We had real trouble not sending them about 5 pages of people. Everyone from, so there's 140 local volunteers at Montgomery Hall's vaccination centre alone, quite apart from the contact tracers. And I think we would want to keep them all. So I guess what I'd say is we've delivered amazing things, but at enormous amounts, so enormous cost in terms of stress, Raj, that everybody concerned. And I think ideally we wouldn't do it that way again. And I think just going back to what Lucy was saying, there are some lessons now about, for example, how do we deliver the flu programme in a way that's a little bit more integrated with the COVID vaccination programme in the autumn. And that's a conversation that we'll be having with the clinical cabinet that represents GP practices, for example, over the next couple of weeks and months. We have a training hub in general practice, going back to what Sadri was saying earlier, that has started a conversation with Tom about the contact tracers on behalf of all the general practices, but we by no means finished that conversation or even really got halfway through it. There's also how do we not lose all the volunteers attached to the vaccination centres as well. And also the vaccinators. There's an awful lot of retirees and students who've come into our system who've all been amazing. So I suppose what I'd say is just on vaccination, there's a deliberate lesson learning exercise going on right now. What you see in here is just a single slide. There will be an awful lot more than that as we plan. We have to deliver the spring booster, but we're planning for the autumn, I think is what I was going to say, Di. And that autumn plan, I dare say we can bring back here once that's ready over the next couple of months.
That'd be good to see, and that kind of fits in with what Sue asked earlier about, looking back on, what communities were engaged and how we can use that information to go forward. So that's brilliant. Gosh, the hands keep going up. Andrew E.
Similar to Gary, I just wanted to build on Tom's response to Lucy about how we get there. It's not just the learning, is it? It's about what we do. So the deliberate approach of doing this review now, the review that Sophie talked about, was to help us for our plans and strategies going forward. So that all the learning and all of the experiences we've been through the last 2 years, which has probably been the biggest public health led intervention in the country's history, in a condensed period of time, how much of that do we want to bake into the future so that we're not reliant on the memories of individuals who will move on to new roles and all sorts of things, but actually how we start to shape the way we do our services is informed by the things we've done in the last 2 years, particularly two points, I think. One, about how do you prevent and how do you take a population-based approach? And then secondly, how you have to take a really important and hard look at the inequalities that are presenting through the kind of impact of the pandemic. So both of those things will be important for whatever we do going forward, and need to inform how we design systems. And the example Gary gave of, you know, how do you do COVID in the same way you do flu? How do you do flu better? Is just one example about how we kind of run public health led prevention programs going into the future. So should be really helpful for our strategy development, and that's the point of getting the learning at this point to kind of mainstream some of that. The health and wellbeing bus might be just one example of an effective way of, you know, kind of getting out and talking to people and being much more community focused.
Thanks, Andrew. Thanks. Should we go to Sue next?
Thank you, Di. I'm going to echo what a number of people have said, I think. When I read the report, the initial report, which read very well, it's a good report, it's an easy read. The one thing that hit me was it didn't really say, I don't think, anything about the toll on very many staff over the last 2 years. And I wondered if when we launch it, we could, I'm sure it didn't mean not to say that, but I wondered whether when we launch it, we could make a special sort of statement as part of the launch, which recognises the enormous amount of work and enormous resilience and creativity and pragmatism that people have shown to get us to where we are in a relatively safe ship sailing well. I suppose that was my first comment. My second comment was that my impression, being somewhat on the outside but highly supportive of all the endeavours, was that when we took control, we meaning you really, I mean Lambeth took control, General Practice Council, we really motored and we really actually achieved a vast amount, despite all the central frustrations and interferences and problems and bureaucracy. And I guess one of the lessons that I'm thinking is that, you know, we could ride high on that in the future, and we intend to, but it was a very positive 2 years from that point of view. And the third thing I wanted to say was picking up on Raj's point that was made initially about anxiety. There is an awful lot of anxiety around, and there's a lot of stress still, but also we have nationally and locally, I think we've learned a lot about how to manage anxiety and stress as a more normal day-to-day management activity, rather when it's possible to do that before it becomes something really much more serious. And I wonder whether we could sort of make a special attempt within each of our alliances to really ask the alliances to focus on, and ask the PCNs to focus on, are we doing the maximum we can to maximise the simpler and simple approaches to helping people manage anxiety, as well as dealing with the much more serious things.
So there's a strong theme coming out about workforce, as well as our citizens being anxious, but the workforce too. We've had new people coming into the system in terms of volunteers, vaccinators, young vaccinators, elder vaccinators. But I think we do have to recognise that we have had workforce leave also. Sabrina, I'll give you the last question, and then I think we need to, and I can see Tom scribbling down some of the questions. We need to have a go at answering some of them, not just Tom on his own, Sophie too.
Thanks, that is just a comment back to Raj's question about support for staff. I've just put in the chat the Keeping Well South East London link that's open to all staff from health and social care, but also within our alliances we're setting up some reflective spaces with our psychology colleagues, and there's things like Schwartz round that's happening where people can talk openly and confidentially about these spaces, and I know our alliance partners as well have got support in place. So I guess there's something about how we share this amongst ourselves so staff are aware where they can go and get support.
Thank you, Sabrina. I think that's much more realistic approach. Definitely. I can see some other comments in the chat as well. Other comments about, actually there wasn't much slack in the system when the pandemic hit, and now we're faced with backlogs. Some backlogs we can count quite easily, and some backlogs we can't, for example, in general practice. Anyway, Sophie, did you want to make a comment and maybe answer some of the comments?
Yeah, I can do. I can answer Sue's, well, half of Sue's comment question, and also there's a question in the chat about publishing the review. To go with that one first, we absolutely will. I mean, it is in the public domain, and you do have it available in the papers from page 63. The question was more just widely disseminating, which we will be doing after today, to make sure it's available for those who aren't reading the papers of the board meeting. And Sue, I just to reflect back exactly what you were saying, which was during the review process. Because, and also as Lucy was mentioning, we like to think of the review as not just the kind of end product, but really the process of the board organisations reflecting. That's the really important bit. But the appreciation of staff and the workforce and the kind of recognition of both impact, I suppose negative, but also the appreciation of just the toll and the going above and beyond and the kind of continued efforts was a huge piece of that conversation and really came from every bit of the system. It is in the review, but I'm happy to discuss perhaps outside of the meeting because it obviously didn't come across to you in reading it. So it is on page 12 of the review, where we sort of put a highlighted section in about colleagues across health and social care in a sort of thank you section, really. And we also were really keen to thank our residents. So not just the workforce, but actually residents who abided by restrictions and public health guidance and helped each other and the like. But perhaps that didn't come across strong enough, so we can look at that and kind of review that, why that didn't happen. But just, I think to say just absolutely that came across and was there, and I hoped was there in the review, but we can talk about in your reading how that perhaps didn't come across strong enough. Thanks.
Great. Have we covered all the points, or were there any outstanding points, Tom?
I don't think there was anything else outstanding for me. I completely endorse Sue's point about local delivery is best. That's not to say anything about kind of national government, but I think we excelled in the local delivery that we had and how we worked together as a system, and I just think that that's one of the challenges over the next period is how we build on from that, how we kind of work with the social capital that built up through the volunteers and the mutual aid groups and so on, and kind of shift that into something that's really going to help us address health inequalities as we go forward, because we know the picture's not great following COVID.
Beautifully said. Andrew, can you top that?
Well, no, but I do. I think this bit about it was all done better locally, etc., etc., etc. There is a truth to that. But we also should recognise some of the national things that were fantastic as well. So the vaccination programme wouldn't have been possible without the commissioning of that research at rapid pace. The things like there's clearly issues about moving at pace, about provision of testing, PPE, all those kind of things. But actually, without the initiation of some of that rapidly, we wouldn't have been able to do the things at local. So I think sometimes it was slow to get to local. Or to delegate, if you like, but actually some of the initiation stuff on a national level has been fantastic. So I think there's a balance to that answer. I think the key thing though is you can't do it without doing it locally. I think that would be my perspective on it.
Great. Well, thank you again, Tom and Sophie, for taking us through that overview of the changes that we have to, what's the word I was looking for, incorporate on the 1st of April. And we're looking out for the new guidance on what we'll do next. Rod, going to have the last word?
Well, staying healthy, Lee, we've been going for nearly 3 hours. I think we should stand up for a minute and have a little stretch, because sitting for 4 hours is not good for your health.
See, I'm sitting on a special cushion, like one of those pressure relief.
Okay, if we all stand up and have a little stretch, yeah?
Okay, I can lead you in yoga stretches.
Raj is showing us his
it.
Oh, he's doing hip circles. I'm doing
muscles, the legs, yeah. The hips.
As long as the lycra doesn't come out, camera off, please.
Oh my. I'm just wiggling my calf muscles.
We used to have regular breaks in the face-to-face board meetings, didn't we? So have a halfway break. We should reintroduce that.
I was just thinking the same thing though, thinking I could really have a comfort break now, but a stretch break is good.
Okay, I feel better now.
Well, so our next agenda item is a staying healthier item. We're going to do our deep dive into the adult weight management project that's been going on, and this is all very relevant for our recovery from COVID. We do know that people who have had unhealthy body mass indexes suffered as a result of getting COVID infections before we had vaccination. So let me welcome Alex Jackson and team. I know you're on the call.
Hi.
I saw you join. Yes.
Thanks, Di.
Hi.
Yeah, there's quite a few of us on the call, so we're going to go through the presentation together. I'll just
maybe the rest of us will switch our cameras off, and then you will then be highlighted better.
Yeah, sure. I was just going to echo what Raj said. I'm actually going to the physio this evening because I have a bad back from sitting down and having bad posture. So I think getting up and stretching during the working day when you're on Teams for so long is definitely a good idea. But yeah, so thanks for having us along, everyone. I'll just do kind of a quick introduction and then we can kind of get going. If you could just go on to the next slide, please. Thank you. Yeah, so the Staying Healthy programme, as most people will know, covers a number of areas. So it covers adult weight management, physical activity, stop smoking services, and NHS health checks. So the focus of today's deep dive is going to be on our weight management community pilot. So there's going to be a number of us, as I said, kind of taking this presentation. The overall aim of this work was kind of to work in a more collaborative way with our local community partners in order to take a place-based approach to tackling obesity. So some of those partners have included Guys and St Thomas and Mosaic Clubhouse, who we're going to hear from shortly today. And the project has also been supported by a wider collaboration across the health system and also with local voluntary and community sector organisations. We also have two service participants, Denise and Michelle, who are on the call, who'll also be discussing their experience with us today. So I thought rather than do all the introductions at the beginning, just kind of as people come in to speak, just if we could just introduce ourselves then, and then kind of we can talk through our various bits.
Yeah, sounds good, Alex. Yep.
Great. Next slide, please. Thank you very much. So just as a bit of background and context to this work, so in March 2021, as part of the government's new obesity strategy, they announced some additional funding for local authorities to support people living with excess weight and obesity to help them to lose weight and maintain healthier lifestyles. So in Lambeth, we actually have an existing weight management service for adults, which is delivered by Guys and St Thomas NHS Trust. So as a partnership, we agreed that we would use this new funding to pilot a more community-based approach to delivering the service with a focus specifically on improving access and tackling inequalities. So we chose 3 high priority areas in Lambeth, which were based on the wards that have kind of higher prevalence of obesity and also high deprivation levels. So those 3 areas were kind of the Vassal Cold Harbour wards, Streatham Hill and Streatham South wards, and then Ferndale, Brixton and Clapham Common wards. So this approach really was about testing out new ways of working. So it's kind of in addition to building on the existing core service and seeing if this new model kind of works and kind of has the impact that we want it to. We also wanted it to fit with some of the council's existing priorities, so particularly around neighbourhood working and the health and wellbeing hubs. So that's again very much about working collaboratively with key local networks and organisations on a neighbourhood and community basis. So kind of working specifically in a local area with some of the main organisations there. So we identified some community-focused organisations in those locations in each priority area, organisations that were kind of based that had kind of good access to local people in order to kind of bring people into the service. So those were Pinnacle, who were kind of working in the Mytesfield North Community Centre, Better Leisure in Streatham, and then Mosaic Clubhouse in Brixton. And as I said, we've also worked with a kind of broader range of partners, particularly around publicising it and supporting people onto the programme, which has kind of included Lambeth's primary care networks, the GPs, and particularly social prescribers, Project Smith Community Connectors, and also the kind of Lambeth Health and Wellbeing Bus and the Thriving Communities Network. So trying to publicise it through kind of some of those outreach networks in the borough. So I'll now hand over to Catherine to talk about the approach that GSTT have taken. If you could go on to the next slide, thank you.
Hi, good afternoon, everyone. My name is Catherine Kironde, and I'm the Early Intervention and Prevention Service Manager with Guy's and St. Thomas's. So we are really privileged to have been asked to take part in this project. We initially we do run the core service for the borough, but we were asked specially to take this work on. And so just very quickly, I won't say much. I only have a couple of slides because we have some very, very important people here with us who are two of our participants on the program, and they will tell us more about what the program has meant to them. But the program is running really, really well. It's for a year, but we're seeing very, very good outcomes out of it. So the program content is, it's a 12-week program, and it starts off with an initial assessment where which we use to obtain the baseline measures, and there we measure the height and the weight to calculate BMI. As some of you know, BMI is the level we use to indicate how overweight somebody is, and though not perfect, it indicates when we need to intervene in order to reduce the risk of people developing obesity-related conditions and other health complications. So the National Institute for Clinical Excellence recommends that BMI level is about 30 and over. But this level gets, the threshold gets lowered, particularly for Black and minority ethnic communities. So we do have a final assessment as well in order to evidence the outcome measures that the patients have been able to achieve on the program. It's a 2-hour face-to-face class. 1 hour is diet and nutrition education, and the next hour is moderate physical activity, mainly circuit-based and weight-bearing exercises. And then we also have a follow-up at 12 weeks after completion, again, to see how people have been able to maintain the changes that they made and whether they've been able to maintain their weight or not. So the inclusion criteria was basically the same inclusion criteria that we have for the core program, but specifically it was for individuals who live or are registered with a GP in the priority areas that Alex has talked about. And then also the target groups were meant to include people with high BMI, which I've explained, but lower thresholds for Black and minority ethnic individuals, and also for people who have obesity-related long-term conditions. So the referral process was different from the normal core service because this was mostly self-referral, whereas with the core service, we take referrals from GPs and other healthcare professionals. But also as part of this, we've had some of the patients have been referred by their GPs. And as you can see in the next slide, we have been advertising the program, and we had publicity materials. So some of the people have taken their publicity materials to the GPs and other healthcare professionals, and so they've been referred that way. If you go back very slightly to the slide before, so but we also have had to gain medical clearance for exercise from the GPs, and so we organized for this to be done. Next slide. So what have we done differently? The key aim of this project, as Alex said, was collaboration with community organizations, and this has really worked very well. We have been working with the community organizations to engage their service users and to deliver in suitable community-based venues. Of course, these are venues which people would be used to, and so we felt that this would be important in order to encourage engagement in the program. We have accepted self-referrals, as I was alluding to earlier, and with a new process for GP clearance for exercise. And then we have lowered the eligibility threshold for Black and minority ethnic communities. So we've had most of the recruitment for the program has been at community outreach events, of which we've had a few since last year. Then we've also had tester sessions in the venues where the classes occur, and with an option for people to enroll directly onto the program, so not to wait for a referral from their GP. We've developed project-specific publicity materials. We've had postcards, posters, and banners, and in fact, as Alex said, some of these have been being distributed at the bus and the Wellbeing Bus and in several of the other venues, the libraries. And so it's been a very good kind of publicity model for us. And then we've also had drop-in initial assessments. Most of the other initial assessments take place in Guy's and St. Thomas's venues. But for this particular project, we've had drop-in initial assessments at the class venues, and we've had a full day of assessments, for example, on particular set days, which has worked well, apart from the normal way where we book an hour's appointment for each patient. And the other plan that we have as part of this project is to work with a men's health group so that we can trial a male-only class. We don't have male-only classes at the moment in the core program. Next slide, please. So the program to date, it started in October 2021. We have run 3 classes so far, as we said, in the 3 priority areas. So the first 3 cohorts finished in March, and the second cohorts have already started, and we have many more. So we have double. We had 3, and now we have 6. 2 that have started and 4 that are due to start soon. Over 90 people were started on the program. This is within the first 3 cohorts, and we've had 60% completion rate. I must say we've noticed that people are engaging much better with the program, maybe because it's self-referral, and so they come in when they are very enthusiastic, as you will hear from Denise and Michelle. So we've had 82% of the participants have been from Black and minority ethnic communities. And we've had about 96%, so almost all of them have had long-term conditions. This pilot sadly ends in June 2022, but we hope that the learning will inform the core weight management service going forward. So I'll now hand over to one of our key partners. It's really been good for us to partner with Mosaic Clubhouse to deliver this program. Over to you, please.
Thank you. Good afternoon. It's Thomas, the Chief Executive of Mosaic Clubhouse. Delighted to be here and to talk about our part in the project, which has been a fantastic success from our point of view. For those of us that may not know, those of you that may not know us, the Clubhouse, based in Brixton, supports people who are living with a mental health condition in Lambeth. And our approach is based on the international Clubhouse model, which embeds co-production between staff and our members throughout all of our activities. And this piece of work was no exception. We offer our members a wide range of activities and opportunities, access to education, and crisis support, information signposting, and other work with other local organisations. The invitation to take part in this programme was fantastic timing for us because it coincided with work that we were doing in partnership with colleagues at the Hetherington GP surgery, with what originally started as having walk-in COVID vaccination sessions for our members, which we thought we'd do in a kind of non-threatening, non-clinical environment to encourage uptake amongst a group of people who have been known to be resistant to vaccines. That was so successful that changed quite rapidly into regular monthly walk-in health check clinics. And so the fact that we were doing this pilot alongside that worked extremely well, because the colleagues from Hetherington that were talking to our members about any concerns they had about lifestyle and about weight and all those kind of issues, we could easily signpost them along. So this fits in with our work extremely well. I mean, we are governed by a set of 37 standards, and standard 28 is one of my favourites, which is that the Clubhouse provides assistance, activities and opportunities designed to help members develop and maintain healthy lifestyles. And what could be better than a class like this, which has been a great addition to our work, because it fits really neatly alongside a load of other activities that we provide for our 340 members, including the fact that in the cafe, as in the picture there in the slide, we've got a commitment to providing affordable, healthy meals every day, made from fresh ingredients. The other thing about our cafe is that we don't serve any high-fat, high-sugar snacks or drinks either. We've got weekly walking groups and a running group, do 2 yoga sessions a week, and also do keep fit sessions. Next slide, please. So we're aware as well that a good reason for us to take part at Mosaic was that it's well recognised that there's higher rates of obesity and overweight amongst people with serious mental illness. So anything we can do to address that has got to be good and got to be a key part of what we do. And the feedback from our members that took part has been incredible. People have absolutely loved it. It's interesting picking up on something that Caroline mentioned